Good morning. Welcome to the February 20th Public Health Nursing ITV. My name is Joy Hoskins. I'm the Director of Nursing. I'm so glad you could join us today. We've got a great agenda. It's about 50 degrees here in Frankfort, so I hope you all are enjoying the warm weather like we are, and we hope that the snow and ice is gone for good for this winter anyway. This session, the entire ITV specifically will be archived as a taped webcast, and so as soon as the Education Workforce Development folks put that into an archived session for us and send me the train number, I'll be sure to send that out to everybody, but just wanted to make sure that you all knew that this would be archived, as well as all the other ITVs are archived. We're very pleased today to introduce our first speaker, Ashel Prutzkamp, who is a registered nurse, and she has her master's degree and her SANE certification. She is currently the emergency room nurse manager at St. Elizabeth Healthcare in Northern Kentucky. She received her master's degree from Northern Kentucky University, and as I mentioned, she is the emergency department nurse manager at St. Elizabeth Healthcare, which is in Fort Thomas, a huge hospital there in the Northern Kentucky area. She is currently on the Northern Kentucky Heroin Impact Committee. She's been on that committee since 2012, and she currently serves as a panelist on the heroin town hall meetings throughout Northern Kentucky. So she is well versed on the subject, and in her position as an ER nurse manager, I'm sure she probably sees a lot of substance abuse and heroin cases as well. Ashel began presenting on the impacts of heroin on health and health care in 2012, and since that time she's made numerous presentations on this topic, and so we're so pleased to have her as a nurse leader and the subject matter expert on such an important topic that impacts all of us today. So at this time, I'll turn the mic over to Ashel, and thank you so much for being with us here today.
Thank you for having me. This has been a hot topic, not only in Northern Kentucky, but I know throughout the state. It's been a long journey since 2012, but and there's been an evolution in this presentation since then. So some of this information might not be all new to you. Some of it you probably are going to be aware of, but I think it's important just to touch base on a little bit of it and give you an idea of what we've been doing in Northern Kentucky and some of the things that we're starting to see. So some of the objectives I'm going to cover today, I'm going to define heroin. I'm going to talk about how it impacts our health. Some of the costs in healthcare related to the heroin epidemic that we're starting to see. And then I'm going to talk about addiction, which I think is very important. And then what are the future healthcare costs that we're going to face. So why the epidemic? I think it's really important, and it's like, how did we get here? Well, in 2012, House Bill 1 got passed, and they call it the state's landmark for prescription drug abuse. The impact that had on us is fewer pill mills, which is important. New pain management clinics must be owned and licensed by medical providers. We must employ medical directors in good standing with the Profession License Board. So they just really wanted to have some better control over the narcotics that were happening throughout the state. More CASPR reports. We have to run a CASPR report on any patient that comes into the emergency department before we can prescribe them a narcotic. We need to know their history. We need to find out if they're seeing other doctors, pain management, if they've been to another ER. That all has to be reported now, and that's really helped, but not helped with our patient satisfaction, as you can imagine. But it really has helped with some of our over abuse of the narcotics that were being prescribed. So it's a good thing. It was been a challenge at first. I think our community is starting to understand the reporting. We have a brochure that we got from the state explaining the new House Bill law and why we're doing and why we can't necessarily give them a narcotic if they're already getting pain management from a primary care doctor and or just recently got one from an ER. So it's been a lot of education, but it really has helped us where we are today. Some of the other impacts House Bill has had is fewer controlled substances that are being dispensed. Again, the CASPR record with 219 million doses of hydrocodone were dispensed in Kentucky in 2011. That's the state. That's enough for 51 doses for every man and woman and child in Kentucky. So it was time. And no one's blaming House Bill 1 for the problem that we're having with heroin. Don't get me wrong. It was much needed. It's just that there was these Mexican cartels, and when we pass this law, they're like, oh, wow, now we have people that are addicted to pain pills that aren't maybe not going to get them. Now we're going to be able to provide them something different. So, House Bill 1 has a lot of great things about it. More investigations on our licensed, suspended, and medical providers, which has been a big thing. We had a doctor in Northern Kentucky who lost his licensing because of his overprescribing of medications. So there is a good things that are happening with that and better control. So House Bill 1 made it harder to get these, which is, your pain prescriptions. And a lot of it is for pain relief. But it's going to make it a lot easier now to get this, and it's heroin. And it's amazing where we've started over the last year. Heroin is a drug made from morphine, from a natural substance. It's a seed pod of an Asian poppy plant. It usually appears in a brown or white powder, but it can be injected, smoked, or snorted. And there's a lot of education. We're doing a lot of town hall meetings in Northern Kentucky, so there's a lot of stigma right now with the IV drug abuse. And so, the last recent data that I did in January, we're getting just as many overdoses from snorting heroin as we are injection. And I think a lot of people think, oh, we're only getting the overdoses from injection, but we're not. We are getting just as many with snorting because these patients don't want to have that stigma and that labeling when they walk into our healthcare facilities or in front of their families. So they're going to snort it just as well as inject it. And so I think people think it's only being injected, but it's not. It's being snorted just as much. And although pure heroin is becoming more common, most street heroin can be cut with other drugs and substances. I mean, we're seeing it cut with powder and fentanyl and starch and powdered milk. I mean, we admitted a 17-year-old to our children's hospital across the river for a lung abscess for snorting heroin. 17 years old, over to children's, because, one of the biggest things is, you're playing Russian roulette when you're doing heroin. You have no idea what you're getting. Us as healthcare providers, you're taking an aspirin, it's FDA approved, you know exactly what milligrams it is, it's 81, you know what exactly that compound is you're getting. When you're messing with heroin, you're playing Russian roulette every time you take it because you have no idea what dealer you're getting it from, what they mixed it with, and we're seeing, we had 2 deaths in 24 hours the other day. My concern is the fentanyl is really getting hot, heavy, they're starting to mix it with that again. It's really intensing their high, it's getting them more addicted, but it's also causing a lot more deaths. And I don't know, I think it happened in Kentucky somewhere, I don't know if you saw the recent article in the paper, but they had confiscated what they thought was heroin, but it was more waxy, and here they had it analyzed and it was fentanyl. So, and it looked like a waxy compound, like they would break it down to make it either a powder of heroin, so it's kind of getting scary. They're getting more sophisticated, I'll tell you. So here's what some heroin will look like. We see a lot more of the white powdered heroin in Northern Kentucky, but we're also seeing black tar heroin. And the black tar heroin is the one that's injected, not that they don't use the white or the brown, but the black tar heroin has to be injected into the veins. They're not snorting this one. They're snorting the white and the brown heroin. This is what some of the paraphernalia is looking like. We see a lot of the white baggies that you guys see on the slide up in the right. There is, we'll see them, they'll put them in their socks. They take like little sandwich baggies that you would buy at Kroger, putting the heroin down and then twist and tying them off. They're small, so they can be easily confiscated and hidden in places. You would imagine where you as healthcare providers know where they can hide these things. But we're starting to see this paraphernalia in our healthcare facilities. We are seeing foil with burns. We have had needles, syringes found in beds inside our hospitals and things. So we're really trying to educate our healthcare providers of what to look for too, because it is a big safety concern with the needle exposures and things. So that's just some of the paraphernalia. And some signs of a heroin overdose. I think it's real important. Most of the time we get our patients, they're usually not breathing. They have low respiration rate, low heart rate. They wear, usually we're pulling them out of a car or they arrive via EMS. They have a dry mouth. Their pupils are real small and pinpoint. And I think you as healthcare providers, when you're assessing these patients that are coming into your clinics and your facilities, their pupils are small and they're tiny, and you can see that. Their tongue may be discolored. They have a low blood pressure, a weak pulse, and sometimes you could just, don't even know what you're doing, but you just want to check their pulse, and you might be able to see some things. If they're a true overdose, they're usually cyanotic. Their lips are turning blue, their nail beds. But some of the things we're starting to see is like they're constipated, but they normally would go into a coma. But what you might see in some of your clinics is what we call a nodding off. And what they'll do is, like, they're trying to have a conversation, or you're trying to have a conversation with them, and they'll just kind of nod their head off. And so that means that they must be impaired on something. So that means you would want to maybe look at their pupils, check their pulse, try to figure out if there's something else going on. You know, Charlotte Wellington got to meet her through this, and she actually is the one that instituted Casey's Law in our state of Kentucky. And she said that, you know, when she thought her son was impaired, you know, he would be nodding off at, like, lunch or whatever, and she's like, you know, Casey, like, what's going on with you? You know, she's like, oh, I'm just really tired. Well, no, he wasn't tired. He was impaired. You know, and she didn't get all those signs that as a mother should get to start, like, looking for. But that was one of the things that she noticed. You know, he always seems so tired and sleepy, and, you know, well, that's because he was impaired at lunch, and she didn't even know it at the time. So one of the things that we use is for an opiate antagonist, and I apologize for some of my slides not transitioning as well as I like, but is Narcan. It binds to the receptors to prevent the neurotransmitter from activating. We use Narcan in the field. We use it in our emergency rooms. The usual onset is 1 to 2 minutes. We do have to sometimes repeat this based on the patient's arousal and their stability. And I have a lot more to share about Narcan later on in the presentation. I'll let you know what we're doing in Northern Kentucky and things that we're moving forward on. But I think a lot of things that are, like, happening is people don't realize, like, we'll give them Narcan, or the field will give them Narcan EMS before they bring them to the ER. Well, then they decide, like, I want to go, because they don't realize that it only has a half-life of 30 to 60 minutes. So there's a chance that you could relapse back into a coma, you know, becoming anoxic, not getting oxygen to your brain, but they don't realize that. You know, I think people think once they get the Narcan, they're fine, they're out of the stupor, you know, they're arousable, they're stable, but they're not stable well enough at all. I mean, we got 90 minutes. We usually try to watch our patients, if they allow us to, in our ERs, at least 3 to 4 hours once they've been given Narcan. Because like I said, we've had to repeat it numerous times. So symptoms of a heroin withdrawal, and this is important to know because if you take care of patients, you know, some early signs of withdrawal are agitation, anxiety, muscle aches, increased tearing, insomnia, sweating. But I'll tell you, more than anything we see is agitation and anxiety. Because once, you know, we give them that Narcan, they got the get up and goes. I mean, they want to get out of there. They want their next fix. They can't wait to get out of the emergency room. They're not the most pleasant people coming out of an overdose, because we just ruined their high, and now we threw them into withdrawal. We did start really working with our community EMS because, you know, back in the day, we would just push 1 or 2 milligrams of Narcan and just, like, rapidly push it. Well, they would already been intubated in the field, and they might, and then they end up pulling their tube out. They come in the ER, they're kicking and screaming. You know, people are getting injured and hurt. So we really started talking to them, and now we're actually titrating the Narcan. So they're starting with 0.4, and they're titrating the dose upon arousal and the patient being stable, which has really helped us a lot. Because, you know, how hard it is to rationalize with a patient who's already agitated and anxiety. Do you think we're going to be able to talk to them and try to provide resources or try to have any, you know, a common sense conversation with them at that point? We weren't, and that was a concerning to us too, because, you know, we can't hold them there. They can sign out against medical advice if they're alert and oriented, but that didn't give us enough time to be able to educate them and hopefully find that window that where we could try to give them some resources and help them. So we've really worked really hard with our EMS. They started seeing a difference too. They don't like them fighting in the back of their squads and pulling their tubes out, so I think they realized it after we started talking about it, so I think it's helped them as well. So some of the late symptoms of withdrawal, and these are things that you might see too, is like abdominal pain and cramping, diarrhea, a lot of GI symptoms. And if they don't really have, like, you know, there's no GI bug going around or nobody in their house is sick, and it seems like it's every time they're coming in, they have some GI stuff going on. It's kind of a red flag. You know, we admit patients into the hospital with vague GI symptoms. You know, they're not always going to disclose to you that they're on heroin or an opiate addict, you know. So those things kind of tend to come out after time when you're figuring out, hey, their CAT scan was normal, their tests are all coming back, so what's going on with them? And those are things that, as healthcare providers, we need to be more in tune with. You know, is there something else causing some of these GI symptoms that they're having? Their pupils will become more dilated versus on the overdose pinpoint. And again, the GI symptoms with the nausea and the vomiting. Oh, sorry. So how does it affect your health? Well, it affects your heart. You know, we've seen a lot of endocarditis in our healthcare facilities related to IV drug use. The veins, they're sclerotic. I mean, think about the foreign substance that you're putting in your body. We're seeing a lot of abscesses for skin. Liver and hepatitis C it's rampant. And if hepatitis C is so rampant, my concern is what is HIV going to end up being down the line, and that's another big health department concern. And the other thing is brain with addiction, and we'll talk about that a little bit more specifically and how it affects your brain. Lungs and pneumonia. Not only are they getting like abscesses in their lungs from snorting heroin, but they're also getting pneumonia from aspirations, from like an overdose, and they're like in a stupor, so they don't realize that they're aspirating. So we've seen a lot of aspiration pneumonia, especially after a drug overdose, getting admitted to our ICUs. So how does it affect the brain? Well, heroin enters the brain where it is converted into morphine, okay? Then it binds to receptors known as opiate receptors. Now, we all have opiate receptors in our brain. We all do. But some people are just more sensitive to the opiates than others. And, just like you can have, 1 out of 4 of your friends is an alcoholic and you can drink socially and they can't, It's just everybody's going to respond differently to the opiates. But and it locates in various parts of your brains, and especially the receptors for pain, reward, and perception. So the reason why this has been so hard to control right now is, this heroin is a great pain reliever, and your opiate receptors like pain, reward, and perception. So they're getting their pain relief, and they're getting a little bit of reward system too by using it. I mean, they're getting such an intense high. They say it's like euphoric. It's like the best thing they've ever had, and then they just want to keep chasing that from here on out. Once they get have that stimulation to their brain, they're like, wow, I need some more of this. I liked it. My brain liked it. And that's really hard to tell kids, when they're like, well, if, we can drink socially, but I don't have to drink every day. But it's like, you don't know what it's going to do to your body from now. You don't know that in a couple years that you're not going to end up being an alcoholic. You don't know that not trying this heroin, that your brain's not going to say, wow, I really like this. I mean, and so how do you try to explain to them that it's not something you can just say, well, I'm going to try it once, and what if I that doesn't mean I'm going to become an addict. Well, it could. And it could definitely, and they say with heroin, this is a drug that if you talk to any of the addicts right now and people that have an addiction disease, they said it's been like nothing else they've ever done as far as drugs go, and they've experimented a lot. So they'll tell you that it's just like nothing else they've ever had. It's like they said, it's just, they love it. And they say pretty much they fell in love with it. Frequent use of heroin can cause irreversible brain cell damage over time. This has been proven. I mean, when you start using drugs, your brain pretty much stops at that age level. So if you start dabbling in drugs in high school, at 16, 17 years old, your brain development is pretty much stopped at that point. And so that's really important to when you're trying to educate, especially our younger population. Heroin abuse in the brain, again, gets to use the morphine. It surges the chemicals and creates a powerful rush, sending intense messages throughout the brain and body for repeat use. And then, again, this leads to tolerance and eventually leads to addiction. So I got a picture of a healthy brain here. And then look at the brain with its overreactive. See all the red in there? That's all that stimulus. So if you have all that activation in your brain and it's craving, opiates and your heroin, I mean, it's just like so active, like give me more, give me more. It's not, your brain is totally taking over all control now. And that's what the heroin will do to you. I just put a slide on here on endocarditis. You can see the damaged valve with the bacteria grows. I mean, the reason why you're getting endocarditis is you're putting, again, foreign substances, you're injecting them into your veins, which is going to get to your heart and cause bacteria infections, and that's where that endocarditis is going to come from. Skin abscesses, seeing a lot of these. Some of them we can manage in the emergency room, but some of them have had to go to surgery, and some of them had to be admitted for long-term IV antibiotics. So how I got all this started is in 2012, in the fall, one of the family physicians in Northern Kentucky called me and said, Michelle, I'm starting to see some heroin addiction issues in my office. Are you starting to see it in your ER? So I'm like, it's been in our ER. We're seeing it, absolutely. And he said, do you think you can get me some data? Well, back in the day when we were doing paper charting, I would have said, you're kidding me because I'm not going to do that, doing all that. But with electronic medical record, I'm like, absolutely. We have this new EMR. I can actually, I'm not just going to look at 12. Let's look at 11, And so it was amazing to me, like where we've been. So it was a great opportunity for me. You know, we've been seeing overdoses. You know, you're nurses, you've been on the floor, and you're like, okay, something's going on in our community, and you know, it's not just in our ER, it's happening in, you know, all of our counties. And so it was a big eye opener for me. So I called him back and I said, oh yeah, we have a problem, and let me share with you what we're doing. So in 2011, and this is just the Northern Kentucky Hospital. So we have a campus in Covington, and then we have an ER in Fort Thomas where I work, Edgewood, Florence, and Grant County. And so these are just known heroin overdoses. Now, we've had our share of other overdoses. We're seeing some Xanax, still seeing some OxyContin and things like that. But I just wanted to pick up only the true heroin overdoses. So, you know, we're going to give Narcan to somebody and they'll say, I haven't taken anything. And if my doc didn't do a drug screen to say that we had heroin, I had to exclude those. So these are just truly known. Some of these patients survived and went home. Some of them went to our ICU and died. And some of them went to treatment. So there's a mix there, and my next step is to try to get a handle on, you know, where some of our patients have gone after treatment. So in 2012, and that's when I called Dr. Engel, and we ended up having 447 heroin overdoses. So you can imagine House Bill 1, I mean, think about it, where we were in 11 to where we are in 12, and now where we are in 13 at 545. I just ran the data for January for the Enquirer, and we had 45 heroin overdoses in January at all of our campuses. So it's not slowing down, but you know what? We're not expecting it to right now. You know, and in this Northern Kentucky thing, like all last year, we really just kind of gathered data and tried to look at our community, and I'll share some of our things with you in a little bit. But we really haven't done enough as far as what's our next steps. You know, now we got to start implementing some changes and some education and resources and things like that. Yeah, we got the data to back us up to tell us we have a problem, which we already knew. But now where do we need to go, and what's our next step as healthcare professionals in moving forward? So I had a nursing student, which I love because then you can get all these things done that you want to get done. I'm sure you guys know that very well working in the community. But I asked her to take a sample shot of those 200 patients for me, and let me know what we're seeing out of that population of those patients that we had that were heroin overdose. 96% of them are white. You know, a small 3% of them were black, and then 1% were in other race. It's about 50-50, as you can see on the sex between male and female. It's not surprising to me because I work in it every day, but I think it's been real surprising to our community and some of our other leaders who didn't know it. But the majority of our heroin overdoses are over age 26. You know, yeah, we're seeing some in high school now and things like that, but why do you think that is? You know, it is because they were addicted to narcotic pain pills before they started using heroin. And so that's been real interesting because, you know, they asked me to talk to high schools and things like that. And yes, it's important, but at our high school level, we need to talk about, you know, not even trying it and prevention and things like that and absence and not even doing that. But where we need to focus on too is, you know, how do we manage patients' chronic pain and get them off of the heroin, you know? And so that's like another big issue. You know, the oldest heroin overdose we had in our emergency room was 60. So that's amazing. I think people don't realize the age. It has no age. It has no classification, nowhere. It's in all of our communities. It's in everybody's backyard. And so, you know, we had 10% over the age 45 just out of those 200 patients. So I think that's kind of something that's, you know, something that people need to be aware of as far as the big age range of it too. There's no age as well as there's no class. The counties, and those are just our counties in our area, Boone, Kenton, and Campbell. Kenton's one of our largest counties, so that's not really that surprising there. But it wasn't surprising either is the self-pay being 65%. You know, a lot of the heroin overdoses that we get are now, they've lost everything. They've lost their jobs, their families, their wife, their kids. So they don't have any insurance. And that's the big thing when it comes to treatment, as you can imagine. Yeah, there are some free beds in a lot of our treatment facilities, but if you have 65% of your 200 patients who don't have insurance and they all need beds, you know, there's just not as many to go around. So remember when I talked about hepatitis C as being one of our biggest concerns? Well, in Northern Kentucky, we double the state's rate at 24 times the national rate in our area for hepatitis C. You know, we do have a bigger problem with heroin, not that the rest of your counties and the rest of the part of the state aren't going to get there and aren't there probably in the same boat that we're in. But we have something unique and different to us in Northern Kentucky than you guys have in other parts of the state, and that's called the Ohio River. And so we have a lot of trafficking that's coming across state lines. And our laws in Kentucky aren't as strong as Ohio's as far as dealing and trafficking. And I know Katie Stein's House Bill 5 is going to hopefully support and change some of that. But that doesn't help us bode well in Northern Kentucky for our drugs coming over to our facilities over in Northern Kentucky. So some of the healthcare costs, and what we did is, I'm going to share some of this. This is from our Northern Kentucky Collaborative Response. We rolled this out to our constituents in November of 2012. We had a lot of support from our judicial system and court system and police and local agencies and everything. But, you know, it costs us statewide $6 billion annually, okay, across the state. That's 9% of our local budget is used for substance abuse. That's a lot. And it's a lot when you're trying to ask for money, too. So, as you guys well know how that works. So, the lifetime cost, remember we're talking about hepatitis C? $64,000 per person is what it's going to cost to take care of a patient with hepatitis C. And if and it's only going to get bigger. And that's why, when you're out talking to the communities and trying to be supportive, we need needle exchange programs. We do. And it's not a popular conversation to have in your counties. Trust me, we've been there. It's not being well received, but we're trying, and the coalitions and the health department are really trying to make some changes there, and we need to. We need to cut down on this rate, and I'm worried about what our HIV is going to do in the future, too. That's still a huge healthcare cost that we're going to be absorbing. Yeah, we have a huge healthcare cost now dealing with the addiction disease, but what it's going to be like taking care of patients with hepatitis C as well. A patient with endocarditis is projected per visit is over $120,000, and they're not just in there for one visit. The actual cost for treating babies born with drug withdrawal symptoms in Northern Kentucky, this is our data from St. Elizabeth based on the babies we had. We had 63 infants in 2012, which ended up being $14,000 per baby. And in 2013, we had over $1 million in babies that were born with withdrawal symptoms. Most of our NICU, the majority percentage of our NICU now is, not premature babies. It's babies who have a drug, who was born with a drug in their system from their mother. And so it's a big concern. And, I was talking to somebody the other day that works in labor and delivery and helps work in the department as far as trying to get out in the community and educate moms and keep them in our system. And, these moms, we're not doing enough to, get our hands around what's going on with them as far as their addiction and their disease. And so what we're doing, though, is we're penalizing when we're taking their babies away and we're putting them in another home, which is a great thing that we're doing. But then it's putting a void in that other mother again. And then so instead of trying to fix her and try to help her with her addiction and work with her on her disease, she's getting pregnant again and having another baby, okay, because she just lost one. And, and so we see that a lot in our emergency rooms. They don't have any custody of their children, but they keep having children. Well, that's because we're not doing the right things for that mother, and there needs to be some ways that we need to figure out how we need to, we have to take the kid away, but then but we don't really do anything for her at that point. We're taking the kids away, but there's no treatment, counseling, things like that, and then they're now filling that other void with another child. So we're starting to see that increase quite a bit. So addiction and treatment. I really don't like this definition because I did take it from Webster, and I know I'm a master's degree, and I got all that, but it's hard when you're out in the community for people to understand addiction, and that medical term, it's too technical and too medical, I think, when you're trying to educate the community. But what I want to make sure people are aware of, and especially when you're talking to your patients and people out in the community, it's compulsive need to use a habit-forming substance. It doesn't have to be heroin, nicotine, alcohol. People are addicted to exercise. Addiction isn't new. It's a disease. People have it. So I think that's the thing. But what we characterize addiction by is the tolerance and the psychological symptoms upon withdrawal. If you can build up a tolerance to something, whether it be heroin, alcohol, or anything, and when you don't have it, you start going with withdrawal, you have an addiction. And that's kind of what I wanted to make sure. And the reason why I like that definition is because I think it clearly sits home with people who don't really understand the word addiction and how it affects them. I think it's broadly perceived as a compulsion to use a substance known that is harmful to you. Again, just like cigarettes and alcohol as well. I really like this slide a lot. I use this a lot when we're educating teenagers. And it just kind of and we're doing this when we're in our facilities because there's a lot of patients who don't want to admit that they have an addiction or a disease. So some of the questions that we ask them are you craving it? You know, are you craving the heroin? I mean, that's kind of important. Have you lost control of your frequent use? You know, how much are you using? You know, yeah, I could only use it maybe on Saturdays, but have you lost control of that? And now you're using it more days during the week than you originally had planned when you started using it in the first place. Do you have compulsion to use? You know, remember when I showed you that thing about the brain cells being so active and, you know, it's like you got to go, 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 go. You know, you're having a compulsion to want to use. And do you lose despite all consequences? And that's one thing that really hits home with people. It's like, you know, you have people that are using have lost a lot. You know, I mean, it's heartening when you take care of you know, a female patient, you know, in her mid-30s who's lost her kids, her spouse, her family support, and her job, but she said she just can't quit. You know, she just can't. The compulsion and that is just taken over regardless of what consequences that she's lost. And she knows she's lost enough. I mean, she'll tell you, I know I've lost enough, but that doesn't stop me from wanting to use every day. You know, and that's just so hard because, you know, it's like, you know, people all the time are like, why can't they stop? And, you know, I don't understand it. Well, this is what I'm hoping to help you understand today a little bit more. So not only can you help your patients, but you can also help your community and your neighbors and your friends who are like, I don't get it. Well, you know, it's a disease. And, you know, and I think that's one of the biggest things that we need to try to focus on. And I talked to you about, you know, why can't they quit? I mean, I think we just talked about this. You know, when you have a non-addicted brain, you have control over things. You make right decisions. You know, you're in control of what's going on in your body and your symptoms and things. But when you are addicted, you lose all control. And the biggest thing you have now is your drive. And that's the drive to use. And it's that your brain, then again, you don't think about control anymore. It's not about the decisions you're making because you don't have the right decision-making process. Your brain has been absorbed now by this active, you know, firing and transmitters that's saying, I just want to use, get me my next fix. That's all I care about. And so you lose all your control, and all you have now is a drive. And we talk about this, and I know I keep saying this, but I like this slide too a lot because I think it really hits home a lot, especially to healthcare professionals. You know, we have a low tolerance for patients who have a drug addiction. You know, I'm not saying I was perfect. I've been in the emergency room 18 years. So there's times where I probably have had my moments that I was like, seriously, again? Like, why are you here again? Like, you know, why? You know, and so you get frustrated when you see these patients and they overdose for, you know, the third time or the fourth time and maybe not the fifth time. You know, drug addiction and we're going to compare this to other chronic diseases, 40 to 60% of these patients will relapse. It's known. You know, yes, treatment works and recovery works, but it sometimes takes a long time to get there. You know, and they'll tell you that. But type 2 diabetes, you know, or type 1 diabetes, I mean, 30 to 50% relapse. I take just as care of many DKA patients in my emergency room who I see month after month who abuse, you know, don't do the right things and get their blood sugars out of control and they get admitted to our ICUs and they're all self-paced and I see them every month. But do you think our doctors and our healthcare professionals treat them a little bit differently with caring and compassion compared to what they do with our drug addiction patients? A lot different. And it's frustrating because even the physicians do it, you know. And so, you know, that kind of registered, you know, hit home a little bit for me. And, you know, especially when you're talking to healthcare professionals, we do have to understand that it's a disease and that they're going to relapse, just like our hypertension patients relapse and our asthma patient relapse. Not everybody in this world is going to be compliant with their disease process. And, you know, I can't imagine being diabetic and being like that strict controlled. I like my sweets. I think that would be really hard for me. I probably would be the 30 to 50% that would relapse. And I think that's really important to understand that with our patients. Try not to get so frustrated. It is, you know, it's going to be tough to get through. You have to think about where their brain is right now, and it's not healed, and they're not rationally thinking. And, you know, you can talk to them, and you're thinking, you know, did I get through to them? Maybe not today, but don't give up, because you might get through to them next time you try to talk to them. You know, they might have that window opening and that eye-opening awake moment that think, she cares about me. She's brought this up the last 3 visits I had with her. Maybe I need to look at myself and see, maybe I can do something. Because, you know, think about this, you guys, with the addicted patients and the patients that have an addiction disease. You know, their families, I mean, and no offense to their families, because they probably robbed them blind, stole from them, lost all trust in them because they probably tried to help them and didn't do the things that they needed to do. But if somebody does care about them and shows that care and compassion, you might be that person that thinks, maybe I am worthwhile and maybe I can do this. because they're not going to have anybody else right now, you guys. And so if you're going to see them in your clinics and in your agencies and things like that, that is one thing that's going to register. And you guys build up rapport with your patients. I mean, you see them on a regular basis, so you are going to be their next family to them. And so that's one thing to just keep in mind. And I hound my nurses, and believe me, my docs don't like me much, because if I hear them being disrespectful, I'm the one that's pulling them in the nurses station saying, listen, really, I mean, you're not going to fix them, so why yell at them, just try to be more understanding of the disease and things like that. So we have a lot of work to do with our counterparts as far as the physician end as well. And I'm they always see me coming, and they always are like, oh, she's out here now, she's out of her office. But I want them to know, like, I'm not going to tolerate it. The patients don't deserve it. And, and then I'll bring up somebody's name, like, again, my DKA patients or our high blood pressure guy. We've seen the same high blood pressure guy, like, I'm not kidding you, 6 times in the last month because of his high blood pressure, because he's not managing it well. And, everybody's always nice to him, and even though he doesn't have any veins, and, because but everybody's nice to him. But I'm like, but you're going to treat somebody that just overdosed not nice, and that really bothers me. So we've done a lot of education. I know in our healthcare system at St. Elizabeth, I educated over 700 nurses in 2013 alone, just trying to get them to understand addiction and the heroin problem. But not only that, just get back to caring and compassion and knowing that it's a disease and we're here to help them. As much as we do get frustrated, and I'm not going to say I was perfect, I've been frustrated before too, but where can we be now? Because we're not going to make it any better for them. And you're not necessarily always going to listen to you. One of the things, and I should have probably moved this slide up, but some behavioral signs of a heroin abuse or addiction, and these are things that you might see too, is like they avoid eye contact with you. Maybe they'll put their head down and not really have a good conversation with you. Increased sleeping. Remember I talked about that. They're nodding off, they're in bed a lot, they're sleeping a lot. And that might be something that you ask, like, family and friends, are they taking care of their family's needs, or are they in bed all the time and their kids are running crazy in their house? That is happening. Sudden performance in either worse in school or work, loss of job, loss of overall motivation. They have no future goals. They're only living for the next moment. They're living for their next use and when the next time they're going to be using heroin. So they're not looking to future goals. They can't see that far. So if you guys are going to try to talk to them about future goals, they're looking at you like, lady, listen, I only want to talk about what's going to happen tomorrow. Like, I can't talk to you about what's going to happen next week or next month. So keep that in mind when you're trying to talk to them and rationalize with your patients, is you have to focus on what are you going to do tomorrow, or maybe an hour from now or 2 hours from now. You can't really, if you get them to think too far out in the future, you're going to lose them because they can't think and rationalize that far out. So focus just on, like, maybe, what are you going to do when you leave here? Or what are you going to do tomorrow morning? But if you get too far out in those future goals, you're not going to have any, they're not going to have any cognitive, conversation with you about that because they can't think that far. They withdraw from family and friends and start spending some things what they call their new friends. Their new friends that'll drive them to my ER and leave them pretty much dead on our doorstep, and then they'll pull away so they don't even stay to make sure that they're okay. We try to talk to them about their new friends. They repeatedly, again, steal, borrow money from loved ones, unexplained absence of values, and things like that. We always talk to our parents about, like, getting a safe and locking up your valuables, and you hate to have to do that, but it's what it's come to. I just talked to a mom the other day, and her son had stole her rings, like, twice and pawned them. She went and got them out, stole them again, and he pawned them. So what she did is she had been in treatment, and she, and of course, didn't succeed the first time, but he did succeed after, I think it was his 3rd attempt, but he actually knocked on the jail's door and wanted to go into jail because he needed treatment that bad, because he just couldn't do it anymore. But his mom didn't feel safe leaving him in her house by herself, that she locked him in his room. She put a bucket in there and said, you're welcome to stay here. You got a roof over your head. But if we leave, you can only stay in this one room. Locked him in there, gave him a bucket to pee in. I mean, he was an adult. It wasn't like this child that she did this. So I don't want you guys to think, okay, she left some 5-year-old in a locked room. No, this was a grown man, adult. But she didn't feel safe leaving in her house. I mean, with her valuables and everything else. I mean, it was like she had to watch him 24/7. He's in recovery now, and he's actually enrolled in a community college. So it's a good story to end with. But man, she said it was a struggle for years, and so it's hard on these families. They're hostile. they're not nice. They always want to blame others, especially when they're in withdrawal. Nothing's their fault, you know. But to be honest with you, they don't really want to be like this. It's the drugs and the addiction and the disease that's taking over. So, you know, they don't want to rationale it with anything. It's always somebody else that's going on. So what we did in Northern Kentucky is we ended up coming up with a resources and some estimated costs that we rolled out. And these are just Northern Kentucky costs, but I just want to share them with you because I think it's important on what we really felt like after our assessment in 2012. This is what we kind of came up with after our assessment. So, and this is what I want to share with you. So we looked at prevention, and it's going to cost over $250,000 in our community to be able to help prevent some of the things. And the reason why this is important is because when we roll this out to the governments and stuff, so they kind of know, in like other agencies and even our own hospital, on where our resources need to come from. But we need to establish more county drug prevention alliances and coalitions to increase community awareness. And we've done that a lot this past year, and we're starting to do more because there is still a lot more that we need to educate our community on. We want to make current information and resources related to best practices available to assess via regional trainings, websites, community forums, and media. There is town hall meetings a lot now. I mean, every county, every church now, just about every school wants to have a town hall meeting. I think it's awesome. And what's great about this town hall meeting, it's represented about, you know, you have businesses, police, healthcare, resources, whether it be our drug and treatment facilities and things like that, all on this panel, sharing what we're seeing in our community and then giving that community a chance to ask us questions. So it's been an awesome way that we try to respond to the needs in our community. You know, implement across the 8 counties prescription take-back days, and this is going to allow parents and stuff to be able to bring their prescriptions or you know their pills that they didn't use the rest of. Say they have surgery, knee surgery, hip surgery, or whatever. Grandma, grandpa broke their hip. You know, got a pain medicine. They don't want it in their house anymore. We need to get those back. We need to get them out of our community. We need to get them, you know, dispensed safely. And so a lot of our police departments actually have a drop-off box where you can drop off your narcotics. So I don't know. I'm sure there's other areas around the state that are doing the same thing. Treatment, and you can imagine, this has got a big dollar sign on it. $2 million, over almost $3 million. What we're trying to do in Northern Kentucky is we need more doctors who are willing to do treatment for an outpatient clinics or medication-assisted treatment. And that's real important because, you know, we have a couple Suboxone doctors in our community up in Northern Kentucky, and I know there's still some stigma and bias about Suboxone, but if your child was addicted to heroin or an opiate, you would want them to be on Suboxone versus playing Russian roulette every day and having a chance of dying. So what we did when we assessed our community is we need 10 new physicians in our community to be able to help treat the disease that we're seeing up in there with addiction. And we don't do, you know, if you have a Suboxone physician, he can only prescribe to 100 patients. 100 patients. Well, you saw my data from Northern Kentucky. We don't have enough. Because if they can only see 100, what's going to happen to the other 445 that need treatment, you know, might need the medicated assisted treatment and can't get it because the doctor's maxed out at 100. That was hopefully another thing that will hopefully get to change in the future is the laws on that. As long as it's, you know, again, everything has to be controlled and done right. And you know, you don't want to have, you know, they're really working on the methadone clinics. You know, you don't want them popping up in all your neighborhoods. I know that's a big concern to our community, but you also can do them the right way to be able to help with addiction in our community as well. Restore funding for residential treatment that's previously been decreased by the state mental health system over the past 4 years, particularly for women, independent children, pregnant women, and those newborns. And some of the funds from Katie Stein's House Bill 5 will put some funding back into treatment. Expand outpatient services to 2 of our 5 counties for adolescent. And I know that the people that do with adolescent treatment is really excited right now because recently there was a settlement in the state of Kentucky for million? I think it was $1 million. And $20 million of that, the governor actually tagged $20 million of that to go to adolescent treatment for drug abuse. And so that's huge for our whole state of Kentucky. So if you're out there doing adolescent treatment, you might want to know how you can get on those funds, but there's going to be funds available. So it's going to be really important to get a hold of some of those. And again, increased funding again for outpatient, intensive outpatient and treatment facilities. and new referrals for the Affordable Care Act. You know, we need to get these patients insured, and I know you guys are probably working on that as hard as we are in our emergency room. And so that's another thing is, you know, making sure we're connecting them to the right resources. Increase funding to break even levels on non-medical detoxification units, and you could save our local hospitals almost $1 million in indigent care. And like I said, 65% of that 200 population that we did a snapshot of were self-pays. So, you know, not everybody's going to get into that Obamacare, but, you know, I know we're working hard. You know, allocate more funding again for residential treatment. And we need to look at not only before, you know, care, but we also have to look at aftercare. And that's one of the big things that we're trying to focus on as well. Protect. Develop and conduct mobile naloxone harm reduction centers. Explore options with the community policymakers to reduce the transmission of infectious disease and remove needles. Again, this is when I talked about, as far as protect, is the Narcan rescue kits and then also the needle exchanges. And neither one of them have been very popular, just so you know, because we've been talking about it a lot in Northern Kentucky. But we're doing it. We actually are doing Narcan rescue kits. They did it in Pendleton County just recently, and I think gave out 8 kits. Currently, right now, these Narcan rescue kits, and I think I have them on here. Oops, I didn't. Sorry. I'll go back. These Narcan rescue kits, and I don't have a slide, and I apologize, but what it is, it's Narcan with an atomizer on it. So it's actually to be injected into the nasopharynx. So you're actually going to inject it into the nose, okay? It's not FDA approved, but it doesn't mean that it's not approved to treat medically. We can use it. It's just that insurances and the Medicaid won't pay for it right now unless it's FDA approved. So they're looking at trying to get that approved by the FDA. A lot of the pharmacies and all that are working hard. But what we're doing in Northern Kentucky, it isn't just for Northern Kentucky, because to be honest with you, I'm doing a lot of work and I really want to roll it out to the entire region. But what we're doing is we're going to get our ER physicians, we're going to be writing a prescription for Narcan. And then we have, right now, I think we have 6 local pharmacies that will dispense the kits. And they're $65 a piece right now. Now, hopefully when, you know, just like anything else, you get more pharmacies to use it, we get more people doing it, maybe we can decrease some of that cost. But if you were a parent or, you know, a family member of a patient who had an addiction issue, you would pay that $65 to have Narcan, I think, in your house. And if you talk to any parent who's lost a child, they would be willing to do that. And we have a lot of support from that. There's been a little bit of concern, you know, just like anything else. It's going to get in the wrong hands. What are you guys doing? You know, or you're, you know, this is what we're hearing at some of the time. You guys are promoting drug use. I'm like, no, we're not. They're going to use it anyway. And Suboxone, the dealers have Suboxone. So, you know, are they going to get on some Narcan kits? Sure. But, you know, what people don't understand is remember I told you about their brain, they're not thinking about, oh, I'm going to shoot up or I'm going to snort heroin because I have this Narcan sitting right next to me. Well, if they're using by themselves, they ain't going to be able to use it. And if they're using with somebody else who's using, who's going to use it? You know, it's primarily for the parents. You know, we had a young kid in Northern Kentucky, Nicholas Beck, whose parents started the website Northern Kentucky Hates Heroin. And Nicholas's parents, he collapsed in their bathroom in their home. They knew he had overdosed. They called 911. They gave him Narcan, but by the time he got to our emergency room, his brain was pretty much anoxic. He was without oxygen to his brain because his dad couldn't get the bathroom door open up. But if he had that atomizer, could he have got there before EMS and at least tried? You know, that was the thing. So they had to, you know, take him off life support because he had no brain function. It's not that, you know, we didn't get him alive. We did in our emergency room, his heart and all that, but he didn't have his brain. His brain was anoxic by then, and there was no other rescue. We're doing a lot of education. We will be sharing this regionally when we get this done. But it's not without a lot of education, not only to our community, but our EMS. These kits are going to be well designed to have education in them. Plus, if you come to any of our medical facilities, whether it be a primary care doctor or our ER, it's going to be an intensive discharge process with, you know, instructions and, you know, because I think one of the big concerns is, especially from our EMS, we're getting some, and I'm meeting with them again on Friday, is they're concerned that they're going to use it but not call 911. You know what I mean? And so, and I could see some of that, but we're going to educate them very well on. Remember when I said it only has a 30 to 90 minute, you know, response, so you have an opportunity to relapse. And so that part of that education is going to have to come from us healthcare professionals, and it will also be reinforced through the pharmacies who are going to be dispensing it. So It's still a work in progress. We are dispensing some of the atomizers and the Narcan kits to our high-risk county communities. And the reason why is because EMS is longer time response there, and there's still an issue there. So they are doing some free kit dispensing there. We've gotten some grant funding. We've gotten some funding from our Northern Kentucky response team. And so they're developing those kits, and they're doing that. I talked to you about Charlotte and her son, Casey, who died. You know, we talk about this, and Charlotte brought this to my attention last year, you know, and it kind of broke my heart a little bit, is, you know, her son, Casey, who did Casey's Law, he died 11 years ago from heroin. 11 years ago. So, you know, I'm up here talking about it now because it's in our forefront and we're seeing so much of it because of House Bill 1, but it's not a new problem. And even addiction isn't new. It's just now we're starting to talk about it because more people are being affected by it. It's just like cancer. You know, no one really talked about it until everybody started being affected by it. And then did it start coming to more funds, more attention, and more talking, and now there's a walk for everything, and, you know, there's ribbons for everything. And it kind of spun into this with addiction as far as this goes. You know, addiction isn't new. You know, alcohol addiction isn't new. You know, our Falmouth treatment facility used to be, you know, the majority of our treatment down there was alcohol, and now it's all opiate. It's all heroin. You know, so it's not new, and I think that's one thing that we need to remind our community of as well. But it's because of the changes that had happened with House Bill 1 and, you know, cracking down on some of that narcotic pill dispensing. Because, you know, the Mexican cartel's like, oh, wow, there's a fresh market up there in Northern Kentucky because they're going to need some pain relief. And those people are used to pain pills, and we used to support them with the pain pills, but now let's get more sophisticated. We can support them with something else. You know, heroin's been around a long time, but, man, the potency and the pureness that's coming out of this heroin that's coming up now isn't anything like I've ever seen. You know, we dealt with heroin overdoses, and, you know, to you people that live in Lexington, I had UK kids come up here all the time to go to Cincinnati because I worked in downtown Covington. They would go to Cincinnati to get their drugs, whether it be crack, heroin, you know, their narcotic pills. They would shoot up in our in Covington in the bathroom right across the river, and they would end up in our ER. And then I'd have to figure out how I'm going to get them home to Lexington, and they haven't even told their parents they even had an addiction problem. So we've seen it, you know, a long time. But to this extent, I think is what's really kind of concerned our community because, like, again, like anything else, it's affecting everyone. And that's really what's kind of brought, okay, well, if it's affecting everybody, now that everybody's aware of it, okay, now we got to figure out how we're going to manage it. And that's really what our next steps are. You know, I know with the Narcan kits, the clean needle exchange that we desperately need to do, you know, and education to our physicians who don't understand that, you know, addiction is a disease. If you can manage my heart and my blood pressure, you're going to have to manage my addiction. And I think that that's one thing that we have to get there. We're still a long ways away. I wish, you know, I know there's some parts of the state that have more treatment facilities than others, so hopefully we can make that happen throughout our state so we can make sure every county is represented well as far as treatment facilities go. And I guess one other thing I want to leave you with is, you know, what do these things have in common? And I've talked about it a lot, so you should know the answer, especially since the slide's there. But cancer, addiction, and diabetes, you know, they're all a disease. And I think that's one thing that trying to educate has been like one of the biggest hard things to get through to people is, you know, because they always think, why can't they stop? You know, I can't tell you that I wasn't one of those 18 years ago saying, really, why can't they just quit using? But man, have I been educated a lot over the last year and a half. So it's been very good. So, question?
Yes. I do have a question. Do you think that the doctors accept the role they might play in this process? And the reason I asked that, when my son was 19 years old, he played football and he had a knee injury. And he came home with narcotics. And I was like, I don't think so. And I took him away. He never took the first one.
Yeah.
And gave him Advil or whatever else, Excedrin or whatever. But I think, you know, the doctor was a personal friend. He knew the kid. He knew the family. But that doesn't mean squat. And I just wondered if doctors are beginning to realize this is, you know, do you see a change in their way of thinking?
Well, I think the only way of thinking that got changed is because of House Bill 1. I don't think if we had House Bill 1, would it have controlled that as much. You know, we had a patient in the ER the other day, and, you know, we're struggling, you know, she's really struggling with some chronic pain issues and got real belligerent in the ER because we weren't giving her what she wants. You know, she has an addiction problem, and we probably put her there. And the reason why I say that and take ownership of that in the emergency room is because she would come to our ER for her chronic pain. And what did she get? A narcotic pain prescription. I mean, that's just what we did. I mean, that's just, you managed the patient's symptoms and you gave them the prescription. So we kind of put ourselves in this place, I think, and especially throughout the state. I don't think that doctors would be as controlled about what they wrote our kids and our adults if it wasn't for House Bill 1. And it's a blessing, like I said, because, you know, if you get a Casper report, you know, on a patient and you know that they're at their doctor's office and they just got 30 Vicodin or Percocet, well, you know you're not going to give them 30 more. You know, I'm not saying that chronic patients don't have an acute disease and have acute pain, I should say, because they do. And there's times where we're going to have to manage the acute pain, but there's ways we're going to have to be able to figure out how we're going to manage it. We're starting to do a lot more IV Tylenol. Actually, they're starting to use it a lot more in surgery and post pain. And patients are starting to respond okay to it. I know some of our chronic pain patients, we've given them IV Tylenol, and we're able to control the situation, not get them so upset with us, and got them some pain relief and pain control. So I think some of that is helping us a little bit. Hopefully we'll be able to get some more non-addicted medications for pain management down the line, especially like using the IV Tylenol and things. But I agree with you. I think without House Bill 1, though, no. We would be giving prescriptions out for narcotics in the ERs left and right, just like we were years ago without Casper. I mean, because, you know, and I think what else is controlled some of this is electronic medical records. You know, before, I mean, so St. Elizabeth merged with Florence St. Luke Hospital, so now there's 5 of us. Well, when we were on paper, you didn't always call the other ER and say, you know, sometimes they would give you a heads up and say, hey, this patient left us, because we weren't really friends then. You know, I mean, we are now, but back then, you know, occasionally in the ER, we all knew each other pretty well because we networked some. But, you know, we'd call and say, hey, this patient left our ER pretty upset, we didn't give him anything for pain, just giving you a heads up. That was pretty cool of St. Luke to call St. Elizabeth and tell us those things. Or we would call UC, you know, we kind of did that a little bit, not really weren't supposed to be honest with you, and not making some HIPAA violations, but it was mainly to protect the patient, but then also to let the ERs know what's been going on. Well, now with electronic medical records, you know, I tell these patients all the time who call me when they're upset because, well, I didn't get anything, you know, I don't understand what the deal is. You're an open book now. I can see that you were at your doctor's office. I can see that you were at GI, and especially if they're in our St. Elizabeth network, and we have a lot of docs in our network now, I can see just about everything. And you try to respectfully tell the patients that now. You know, the reason why is because you realize you had 16 ER visits, you know, all of last year between our 3 campuses, like 3 main ERs. And they're like, really? I'm like, so it's hard for our doctors to prescribe you when they see all of this. And so I try to, and I think that helps the conversation go really well with the patient, because I just, it's black and white. You know, you can't hide much like you used to anymore either with electronic medical record. And I explain that to them. You know, with our Casper reporting laws and things like that, you know, they get so mad at the docs, but that's because there's a respectful way to tell them and there's a non-respectful way to tell them. You can't go in there and say, well, look at this. You've already been here, and I can't believe, you know, you want me to write you for something, and look at all this. Instead of saying, we have a new law. It's called House Bill 1. I have to run a Casper. This is what it showed. So by law, I cannot prescribe you anything other than, you know, something that's non-narcotic. And so those are ways that we're trying to work with our physicians on and educate stuff, because it is still a problem, like you said, you know, but without that being on there, we would still be giving it. You know why? Because they don't, no offense, but, you know, it's customer service, which we're getting, you know, that's always a big standard you're trying to make sure you maintain. And when you're getting a bunch of patients upset because you didn't give them any narcotics or you didn't give them anything to manage their pain, then they're calling the administration, they're calling the hospital and things like that. One thing that I do like about our ER docs now, though, lately, even if we do have to manage acute pain on a chronic patient, they're not getting the quantity that we used to give them either. They're maybe giving 5 until, like, especially if it's a weekday, knowing that they're going to be able to get into their doctor's office in the next day or 2. We're not writing 30 and 20 like we used to at all. I mean, you know, I had surgery and I only got 10, which was fine. Like, I didn't care. But I think that there's a lot more emphasis on the amount too, which is a good thing. You know, I think that control is good. I don't think you need to write 30 for somebody that, you know, nowadays with surgery and the sophistications of the robots and everything else, there's not as much pain to manage like you did before with a huge incision. So I think that that's really helping too. They're not giving the quantities that are out in our market like they used to be. So I think that helps.
I'm from a very small rural county without a hospital or any type of 24-hour urgent treatment center, but we do have our numbers of our addictions.
Mm-hmm.
One of the newest projects is trying to get a Suboxone clinic into the community. Now, it's probably got a lot to do with misunderstanding and lack of education, but we have one physician's office visit that is adamant that this is not going to happen. Now, how would someone go about, without taking you personally to Powell County with me?
You want me,
Right.
because I can help.
Yeah, to show that benefit, because they even have this healthcare provider's office even has the police department against this clinic.
Mm-hmm. And you know,
And after listening to you, I can see this is we have not looked at it properly in the county. And the majority of our people, I think, want to keep their heads in the sand. Almost every single family in the community has someone that is addicted, whether it's, heroin or alcohol or tobacco. But how do we move forward? I mean, maybe that's not what we should have done. Maybe that wasn't the best place to start. But I know the prevention part is very difficult with the small police department. Keeping the heroin out was an impossible task. Our jails are covered up with people that are addicted, and not necessarily the dealers, but these are the people that they catch on the street. So now we have drug courts. Drug courts are putting them into outpatient treatment, but it's not medically supervised. It's mainly counseling by religious organizations, and we're not getting anywhere. It's like we're at a standstill, and it's just getting worse and worse. How would you, or where could I find the information that would be?
well, I can give you the link to our Northern Kentucky plan, so I can send that out to you all. I think that's important, especially for other counties, because it kind of gives you the grassroots on how we started. And one of the big things is you're going to have to go get your community together. Have a town hall meeting and kind of do what we do and explain what's going on. People didn't listen very well right away for us either. I mean, like I said, it's taken us just a year and a half to even get to this point that we're really starting to really find out what we need to be doing. But you're right, there is a lot of biases, but it will save lives, and because you can't control what's going on right now, that might be something that's going to save lives for your county right now. The police officer departments can get Narcan though. That House Bill 5 for Katie Stein, that Good Samaritan law is in there. We're teaching our police department in our rural counties. They're going to have the atomizers so that they will be able to use them. So that might be something to look at too, because that can save lives until they can get to the nearest hospital. But I think the one thing you need to start with is just in your count, try to pull your community leaders together and start sharing the facts with them. This is what Northern Kentucky's done, and it's taken them a while, but we could get there too. I know we can, and just give them that rah-rah, I know we can do better, and we got to do better for our community. But, pulling some of the big leaders in your community together and just tell them you just want to clear up the biases. You just want to give them the facts. I mean, there's nothing in there that I'm not going to tell you. It's not anything they're not going to know. But I think sometimes when you clear some of those myths up, it makes a big difference. And I think that's what's so hard. We've seen methadone being abused, and I know you guys have seen it in your communities too. So it's hard to swallow because you're like, they're on methadone. And I'm thinking, but then I've educated myself over this last year and a half, and they're contributing to society. They have jobs. They're taking care of their families. So if they're on methadone, I know it's not the greatest thing that we want for them on right now, but maybe that's what they're going to need to be able to contribute to society that we would want them to do. And that might be the only way they're going to be able to do it. Because there are going to be patients that are going to do recovery and treatment and not going to need any kind of other thing. And there's other people who might need to be on Suboxone. They're not going to be able to do it because their brain is so active that they need something to calm it down so they can listen to treatment. That's the other thing. Suboxone will help them get their brain to start healing so they can start accepting the treatment. Because if their brain's not starting to heal and it's so active and you're trying to give them treatment, like I said, you saw all that in red, you're not going to be as successful as you would like to be. So I think just getting your community together and start sharing facts. This is what's happening in our area. This is in Northern Kentucky, and we're not far from it here, to be honest with you. I think after looking at Northern Kentucky, we're in the same boat they're in, and look where they're doing. So maybe that would help you. The fact thing and trying to take away the myths has been hard. I'm not going to tell you all of our docs in Northern Kentucky are on board because they're not. Because you know how many times I hear, well, I don't want those kind of patients in my office. They're in your office. They're in your office now. Like, but they don't want to, like, they don't want to prescribe Suboxone out of their family care doctor's offices. They want it to be a separate clinic. They want to, they only want them to come there. They don't want to mix with the rest of their population. Don't get me started, because they're in our population right now. You're walking down the street with them. You're in the shopping malls. But, so that's something we're still really working hard on up in Northern Kentucky, to be honest with you. So I understand your frustration, because I still frustrated with it every day too. But get your community leaders together, and I think just having a fact-finding day and say, listen, let me clear up some things, and what are your questions? And then maybe you can get some answers for them, and like I said, I will have Joy share my email address, and, we have plenty of partners in Northern Kentucky, and I think one thing that we're most proud of is this isn't just Northern Kentucky. We want to share this across the region and the state. I mean, Dr. Engel is one of the ER docs that kind of forefronted a lot of this back home for us. But that doesn't mean that, because when I told him we were doing the Narcan and where we are just in our own facility, he goes, well, you're doing this regionally, right? You're going to make this a regional plan. I'm like, I get it. Because we all want to make sure it's best for everybody. We're not just siloing ourselves in Northern Kentucky and we're not going to share it. We're working with Hamilton County in Ohio and, any of our partners in Northern Kentucky and throughout the state. We want to be able to share what we've learned and help you guys maybe get some resources and things that you haven't been able to do either. So that's one thing that I think we take pride in is, and if it makes me coming down here, you let me know. You just call me. So I'll come. So thank you all again for having me. Thank you. Thank you.
Thank you so much, Michelle. You did an excellent job. So much valuable information. And again, this presentation will be archived for nurses in your local health department who may not have been able to participate today. We'll be able to have that available to you all at a later date. And I'm sorry, we're going to.
I'll get you that Northern Kentucky Plan website, and it'll be a link you guys will have to go into. It's a huge PDF file, 70-something pages. So I'll get that to Joy, and then she can get it out to you all as well. Okay.
Absolutely.
All right. Thank you again.
Thank you so much.
Thanks for having me.
Michelle, do you know, will you be able to get out, or do you want me to have somebody walk you out? Okay. Thank you, Sarah. Thank you. Nice to meet you, Carrie. Thank you for coming. Northern Kentucky is very well represented today on our agenda. Our next presenter will be Jennifer Hunter, who many of you all know is the Director of Nursing for the Northern Kentucky Independent District Health Department. Jennifer was here approximately 3 years ago to provide her information about her immunization QI project, the startup, the data that she had used to initiate the project. And I asked her this morning how long it had been since she was here with that initial presentation, and she said 3 years. And I told her I would have guessed, a year and a half or 2 years. So it's actually been 3 years. And so we wanted to bring her back and provide the final results of her successful project. And many of y'all, I know, have similar projects, the QI projects, and maybe some specifically to immunizations. So we thought this information would be helpful to everyone. So thank you, Jennifer, for also coming down from Northern Kentucky today. And I'll turn the mic over to you.
Thank you, Joy. We're doing great things in Northern Kentucky. If you can't see, I'm pretty biased about what we're doing. And as an addition to what Ashley was talking about, the Northern Kentucky Health Department is very much involved with the Heroin Impact Committee. In fact, my district director, Dr. Sadler, is on the leadership team of the Heroin Task Force. And so we were very much involved with what Ashley's doing and educating people. And as a matter of fact, Joyce Rice, who's our epidemiology manager, and myself were chosen to speak at the KPHA conference this year on the consequences of the hepatitis C epidemic in Northern Kentucky. And thanks to DPH, CDC, and Kathy Sanders, Northern Kentucky Health Department has been doing a pilot study for about almost the last 2 years, and we're going to present our data at the KPHA conference this year. So if you're interested in that, you can, please look us up for Joyce and I to come watch for that. Anyway, what I'm here to talk about is, Joyce said, my name is Jennifer Hunter, and I'm the Director of Clinical Services for the Northern Kentucky Health Department, and we cover 4 counties. We cover Boone, Kenton, Campbell, and Grant counties in our district. See this beautiful face that's looking at you? This little calm, beautiful face is the face that will come into your health department, and you will want to do everything for this calm, beautiful little face, especially immunizations. Immunizations over the last decades have been probably the most important public health tool that we can have to decrease the incidence of childhood vaccine preventable diseases. And really, health departments are looked at as experts in the community, at least in Northern Kentucky, they are. We know what to give so that our population does not get sick from the immunizations that children can have. Hence, this is a before picture. This is the after picture. This is just kind of like a picture of what a normal face looks like when we try to provide immunizations in one of our 4 clinics. And to give you kind of like a look at what I'm talking about for our 4 clinics, our 4 sites gave over 12,000 vaccinations last year. So we saw 12,000 of these faces when we're trying to do our good deed. Immunizations, and this is something that you all know and that I'm not going to go over, but there's a schedule for whatever developmental period the child is in, what doses are needed. But by the age of 2, if you look down the list, there's quite a few different types of immunizations that a child should have to be protected, not only for their own self, but kind of for herd immunity for the community, so that the community can stay safe from these immunizations so you can't pass these dreaded diseases back and forth. So as you see, there are 7 different vaccines, but there's 19 different times within a child's first 2 years that they should come in contact with a healthcare provider. In our case, I'm talking about our health centers. As goals for immunizations, as a director of nursing, I'm always wanting my clinics and my health department to either, be at the goal or be higher than the goal. And so in looking at immunizations, the Healthy Kentuckians, and I know we haven't updated for 2020, but the national and state goals are at 90% coverage rate. And so that's kind of like the goal that I was shooting at to look at when I first started this project. This is a list. I started looking at data all the way back in 2004. So really this project is looking at 10 years worth of data that I think is really good because we always talk about local data, data-driven decisions based upon policy and what's best for your community. On the side of it, it lists each one of our counties. And so I looked at Boone, Campbell, Grant, and Kenton County. And then across the top is the year. And if you look at across the top, you might see under 2004, there's a 431, 331. That was the sequence that was used to judge what your immunization rate was at that time. And if you look at 2009, there's a little bit of a change because that's when we had the Hib recall and we had some of the vaccines weren't coming in on time. And so there was a different schedule that we looked at. But in 2009, when I decided to look at this and look at all of my numbers, they didn't look very good to me. Once in a while we'd pop up and we'd have a really good 90%. Grant County even one year had a 100% coverage rate, which was great, but everything else was just kind of blah. And in Northern Kentucky, we don't deal with blah. We deal with very high standards. And so what I decided to do was, let's get people together to talk about this. We want to be at the 90% or higher. What can we do to get up to that level? After comparing us to each other in our district, I thought, well, what's Kentucky doing and what's the nation doing? Let's compare Northern Kentucky Health Department to both of those. And as you can see, we're at the bottom, the Northern Kentucky Clinic average. We were still a little bit higher than the state of Kentucky and maybe somewhat higher than the nation, but still, these numbers weren't good enough for me. So what I thought, what can we do about this? And the more I thought about it, it wasn't just a nursing issue. When you're looking at continuous quality improvement, you need to involve everybody in the process, not just the nurses who are giving the vaccination. So I got together a number of people, and you can see on the slides, from our immunization program manager, quality assurance manager, to clinic managers, support service managers, nurses, and clerical, everybody. I wanted everybody's input so that we can map out the process. What happens when someone comes to our clinic and we make an appointment for them and they don't show up? What do we do after that to get them back in so that they can be immunized? And we did a big mapping process and getting everyone's input. Again, it's a whole team concept, not just nursing. So we brainstormed, and we wrote down different things from different perspectives. One of the things was everybody has to make immunizations a priority. It can't just be a nursing or a medical priority. It needed to be an all hands on deck. That means everybody in the clinic had to get together and see where their place was in the process, to make sure children were getting their immunizations. We decided we needed to develop a communication system, to alert somebody, in that chart, since we don't have electronic medical records. We use the high-tech sticky system. That child needs immunization. Don't let that child go out of the clinic before they see a nurse. And what can we do if they miss their appointment? Let's make a more in-depth process for tracking them. So in May of 2010, because of all the data that I had gotten and the mapping policy that we did, I instituted a new policy, and it was an immunization documentation policy. And in the policy, it listed step by step what we should do if anyone comes into the Northern Kentucky Health Departments. If they're coming in for any service, it didn't matter what, not even immunizations, what we should do for that child to make sure we either had the immunizations documented or we did any follow-up. What do we do for missed appointments? We developed a 3-point system that when someone was a no-show, we would go ahead and send them a no-show card for a first attempt. Then we'd have a specific immunization clerk or other staff member who would call them a second and third time to make sure that we were getting them in. If somebody needed during a WIC visit and they needed an immunization, that was marked on there too. So we did a first, second, and third attempt. Once all those attempts were up, it was very important for us to document that in the record, because if it's not documented, it's not done. As I talked about for WIC, even though WIC is not a medical service, we went ahead and made sure every chart that came through our WIC clinic actually was looked at their record, see if they had an immunization record, and if a nurse needed to call to see if they could bring in their immunization records next time, or if they were getting care somewhere else, so that we could document that in their record. Then I also instituted an audit process. Our immunization program manager, Sonia Mosley, she received a report from the state. It was called a missing immunization list. And that list contains all the 18 to 24-month-old children from each county that you can look at to see who missed their immunization appointment. And then again, we sent out information to them and tracked them 1, 2, and 3 times to get them in for the immunizations. I know it's really hard to see on this, but this is the actual policy. And if anyone is interested in getting the actual policy, and like Joy said, I've talked about this before, and I've sent this out to like 6 or 7 health departments who have wanted the policy. Like I said, it's so hard to see on here, but you can get with Joy or get my contact information, and I can send you the template. And all you have to do is insert your health department and maybe insert specific, maybe your names of your employees are different than my names are. But we do have the policy change available for any health department who wants it. And basically, it's a step-by-step procedure on what you do for any missed immunization appointment. Well, 6 months went by, and I was ready to see some great results, because if you tell somebody to do something, they should do it. And that's me right there with the things that I shouldn't say out loud. At my desk when I was all excited, and I got our immunization report in December of 2010, and I looked at our results. And that's not what I wanted to see. I couldn't figure out why. The policy was written correctly. I had all of the right people in with me to help me make the policy, but the numbers didn't show. As you can see, we were still under 90% for all 4 of our sites. Grant and Kenton was above 90, but we looked at it as a district also. So again, it wasn't good enough for me. So if anybody knows me, I continue on up the mountain. I continue with my charge, and we continued the process. We didn't stop. We continually, constantly kept following our policy. We put an emphasis, we re-educated people that it's a team effort, and really we changed the culture, that each clinic should really focus on immunizations and what they can do not only to serve the children who come to see us, but the community in which they live in. A year later, I finally got what I wanted. In December of 2011, all 4 of the Northern Kentucky Health Center sites were above 90% for immunizations. And not that I'm bragging, we were even above Kentucky and the nation for immunization rates, as you can see on there. I was so excited, and so was everybody else. We finally got to see the outcome of a policy change. A simple policy change that we thought, but it took a year and a half for this project to produce the results that I wanted it to. And it was also the first time in the history of our health department, Northern Kentucky Health Department, that all 4 sites were above the 90% coverage rate, which we were really proud of. The one thing that I can contribute to this, it was teamwork. It wasn't me, it wasn't the management, it was all of us working together to find out what process needs to be put in place to get those results. So what did I do? I spread the good news to anybody who would listen to me. I spread it to, obviously, to my supervisor, Dr. Sadler, which she spread it to our district board and all 4 of our local boards. We did media releases, we did press releases, we had it on our Facebook, our Twitter accounts, our employee newsletter. Of course, I emailed anybody who would listen to me down at DPH down here. Dr. Mayfield, Joy, Margaret Jones, Lara, Dr. Humboldt, Dr. Connie White, Dr. Shepard, Dr. Brawley, the Kentucky Immunization Program, like I said, anybody who would listen to me. Because I was so proud of, you read all the time, when you're in public health, you need results that are local, data-driven results. And this was a pure example of a data-driven result that had a good outcome. My future plans with this also is working with the American Nurses Association. I've submitted this to NACCHO, so I'm looking forward to getting a response back from NACCHO to be considered in one of their publication journals. The Kentucky Nurses Association, APHA, KPHA, which I spoke at last year, and then a number of other high-level organizations. The process that I use is similar. It's similar to what we in public health use all the time and nursing process. The American Nurses Association talks about the nursing process. Of course, it's a constant cycle. You can't stop anywhere in the cycle for a continuous quality improvement project. You have to assess, diagnose, plan, and evaluate all the time. So I use that standard. Also, the ASTDN, the Public Health Nursing Practice Model, I use that also, which is basically the same thing of policy development, assurance, and assessment. And then we all know this color. We all know this ring of different colors from the Public Health Competency Handbook. Again, the same system is in place for a quality assurance project. The good thing is, last year in February, Northern Kentucky Health Department was one of 11 in the whole nation that was accredited by the Public Health Accreditation Board. And we used this project as one of the documentation projects that FAB got to look at for our accreditation. And so they were very happy with this. And one of the things that they talked about with this special project, again, was we made a policy change. It's a public health issue. And we made local data-driven decisions with it. Now, as a continuous policy, we continued it, but guess what? A smidge, we slid back in 2012. Now, if you look at any terminology book, you can look at smidge in the terminology book, and it means just a little. So this process had to continue for us. In 2012, one of our counties went down to 87%, but one of our counties went up to 99%. So when you have a smidge, either way, plus or negative, you have to look at why you had that smidge. So what we did is we went back. What did we learn from that evaluation? Why did we go down at our Boone County Health Center? So we went back and looked at all the immunization records that we had audited, and we did find something. We did find that the same nurse and nurses were making mistakes. And so that was a learning curve because the nurse was given the doses before they were due. So on that note, we did an educational campaign to those nurses because those doses were basically invalid. They didn't count, and so that's why the level went down in the one county. And so we provided education at that site again. Of course, it's not punitive. It's just education to get back on track where we needed to be. Why did Grant County go up? Why did they go to 99%? Well, what we found out with, obviously, teamwork and Grant County had, they did great at their documentation. So their culture of their staff was to document everything they did for immunizations. They did it every time they came in for WIC. They instituted the patient reminder system and never looked back from that. And they also made sure they rotated vaccine stock using the earliest ones that expired first. A year later, we got up again. So a project that we've been doing for 3 years, continuously going back, assessing, planning, implementing, and evaluating, finally got us back up. And the 2013 numbers were from December of last year. Kentucky and the nation, I didn't know what those results were. But if you look at that, all 4 of our counties were very high in the 90%. And one of the biggest things that I learned about this project is it's never going to end. So when you start a CQI project, you can never say, okay, we made it, and then just stop and not do anything about it anymore. You have to continually reevaluate what you're doing, like we did in 2012. When you reevaluate it and something happens that you don't want it to happen, you have to get in there again and constantly reassess what you're doing and change your plan. So I'm very happy with the results from the Northern Kentucky Health Department immunization CQI process. And if anyone has any questions on it, I am not on the global. Our health department has our own email system, so my information is on here if you have any questions that you have about the project, or if you want to get in contact with me to get the template, you're welcome to do that. And I do want to thank again Joy for inviting me to talk about our successes in Northern Kentucky.
Thank you. Are there any questions for Jennifer before she sits down? Any questions from the field? Thank you, Jennifer, for coming back and sharing your successful CQI project with us. And that was a great idea to share that with the FAB accreditation team. And so great project and great success. So thank you for sharing that with us and folks out in the field. Next, we have TJ Sugg, who is one of our epidemiologists in the reportable disease branch. And TJ and I, as you all may be aware by now, have collaborated on offering ERRT hours through our public health nursing ITVs. And so this is our ERRT offering this ITV. I did send out ERRT attendance verification form with today's agenda. So you'll want to make sure that if you need those hours and you're requesting those hours, that you complete that form and submit that through the appropriate approval process. So TJ, thank you so much for taking time out of your busy schedule. TJ was at EKU yesterday afternoon presenting were they MPH students?
Yes, in the epidemiology course.
Yes. So he's a busy man, and so we appreciate you so much for you coming and sharing your time and expertise with public health nurses. Thank you.
Thank you. Hey, before I get started, I just want to give you all some updates regarding some upcoming training sessions that we're offering EpiRapid Response Team credit for. The first one is the ESFA conference. Some of you may have heard about that, and it is open to local health departments. And the Preparedness Branch and the Kentucky Hospital Association are working together to put on this conference. Of course, EPH is taking the lead on coordinating this, and I was asked to join in their planning to create an EPI track, which they've never had before at this conference. And so we have several different, I think we have 12 different public health or, sessions that are, pertaining to epidemiology and public health. And that will be March 3rd through the 5th in Louisville at the Crown Plaza. It will start the afternoon of March 3rd and go through, it will be the afternoon of March 3rd all day on the 4th and then the morning of the 5th. And I think the preparedness branch is going to allocate funds to local health departments. I know that's been a discussion point, so I'm not for sure on that. We have a meeting today at 1 o'clock to discuss that in more detail. So hopefully we'll have more details after our meeting today. But I think they were going to allocate funds to local health departments to send their staff. And so, so that's, of course, maybe of interest to nurses and epidemiologists to go as well. Because we're going to have sessions on norovirus, foodborne and waterborne investigations, scabies outbreaks. I'm going to talk to you about scabies regarding our public health response. And then some of the audience, or some of the audience that will be there are local, long-term care facility representatives and hospital personnel. So the presentation that I'm giving for the ESFA conference will be what their role is and what our expectations are and how we can work together for scabies outbreaks. I think Andrea Plincham is going to do a session on healthcare-associated infections. We also have Jan, she's going to do a section on influenza. And then we have some other presentations too. We have 12 slots that we're going to be presenting. So take a look at it. It's on Train. So if you're interested in going, of course, discuss that with your director to see if it's possible for you to attend. And registration, I think, ends on Friday, which is tomorrow. So talk fast if you haven't if you haven't heard about this until now. So it may be something that you're interested in. So, and of course, the full agenda and all the course objectives, and they have, we've been awarded continuing education hours for nurses, environmentalists, and things. I think they're working on social workers and CHES as well. And of course, ERT credits will be awarded for each session, 1 hour for each EPI session. So, another opportunity that's coming up for continuing education for EPI Rapid Response Team is at KPHA. We started this last year with offering ERT credits for the KPHA sessions. This year I'm serving as the chair of the EPI section for KPHA, and we were given 3 sessions originally, and we were actually given 1 more, and we've awarded EPI Rapid Response Team credit for all those. One of the sessions is going to be on tuberculosis. We had a graduate student, Claudia Valdivieso. She worked here on a TB project, and she analyzed, I think, 17 or 19 years worth of TB data. And she divided that into 2 time periods, and she looked at the differences in our TB cases in the these earlier years in the 90s, and then compared that to our recent TB cases. And she looked at the clinical information, the demographic characteristics, and it's a really fascinating study that she did, and that she used that as her project for her MPH, her capstone. So she's going to present, and then we're going to have the TB staff there, sort of a panel discussion. And they're going to provide some updates with the program and the current status of TB cases in Kentucky, and then we'll be there to answer questions from the attendees. Another session, we're going to do one similar to what we did last year with the Kentucky EPI in Action. We're going to have 4 different small presentations within a session. We're going to talk about some investigations that we've done. This year, thank goodness, we haven't had such an active year where we have multiple things to discuss. So we're going to talk about some investigations that we've done, not necessarily outbreaks. And we are going to have some local health department personnel, too, presenting on their experiences. And another session is on spatial and geographic epidemiology. So it's how GIS can be applied to not only infectious disease investigations, but for public health programs in general. And this isn't an overly technical presentation. You don't have to have any knowledge of GIS or anything like that. It's just an introductory level just to show you the power of geographic information systems. So that will also be a session. And Brendan O'Banion will be discussing In another session, we were given this fourth session because one of the groups couldn't fill this one, so I asked for this because Brendan approached me and wanted to present. And Brendan is going to talk about the Kentucky Health Information Exchange and disease surveillance and how all that is currently working together and what the future plans are, for that to kind of make reportable or notifiable disease reporting more automated. So those are some interesting sessions that you may be interested in. There are also 3 environmental sessions that we've awarded EpiRapid Response Team credit for as well. One is on large event data collection technology. That's become important in recent years as far as environmental inspections and the importance of having electronic data for all of their environmental health inspections. So we awarded credit for that. There's also one, the Kroger company is going to come and talk about how they work with tracebacks and with public health and how they track their products and that sort of thing. And that came into play with a recent salmonella outbreak. So we worked with Kroger and were able to get lists for what people purchased with their Kroger cards and things. And so we were actually able to do some follow-up that way. So Kroger is going to come and talk about that. And because of what we experienced with the salmonella outbreak with cantaloupe, we thought that this would be a worthwhile presentation too, because it was a pretty cumbersome process to figure out where those melons came from, and we had to work very closely with environmental health and food safety here to piece all those parts together to come up with a hypothesis for where those cantaloupes were contaminated. And then the other session is neglected tropical diseases of the U.S. Dr. Barnett at EKU is going to talk about dengue and Chagas disease. And so we've awarded credit for that too. He's going to talk about the epidemiology of that and why that's a concern and why we should be concerned about it in public health. Any questions about those? Oh, and KPHA, it starts I think it's the 14th through the 17th. The 14th is like a preliminary day. We're going to have a lot of group meetings, and they always do an RS exam too on that day. And then the actual conference with all the sessions gets started on the 15th, and it goes the 15th full day, 15th and 16th, and half the day on the 17th. So take a look at that. I think Justin Pittman, who is leading the effort, our conference planning, sent that to all the local health department directors, a draft agenda. So if you're interested in that, ask your director. They should have a copy of it, and to take a look at all the sessions that are available. Okay. Any questions? All right, well, I guess we're going to go ahead and get started with the scabies presentation. And my goal for today is to make you itch by the end of this presentation. And the reason I decided to discuss scabies is, well, I'm the scabies contact here, and recently I received a lot of requests for information and guidance on how to deal with scabies outbreaks and things. And so we don't really have an all-in-one guide here in Kentucky that we use. We use several different ones. And so I am in the process of creating one for Kentucky using various resources that I'll list here at the end of the presentation that we use routinely. And if you contacted me with an outbreak, and a lot of the reports that we get are from long-term care facilities, scabies outbreaks in long-term care facilities. And I will send those resources usually to the regional epidemiologist or to the nurse who contacts me. And, we kind of walk through the process. And we also, we assign outbreak numbers, and we track that just like we would an infectious disease outbreak. So it's important to report those to us and to get us involved early on in the process, because if it's not handled properly on the front end, you can have these ongoing infestations. And that's something that we definitely do not want in our healthcare facilities or long-term care facilities specifically. So the objectives I'm going to describe, and I do apologize. As Joyce said, this has been a busy week, and I just finished this presentation this morning. So she just now got it in her hands at 10:45, and I joked and told her, I said, "You're going to get it at 10:45," and sure enough, that's when she got it in her hands. So we will send this out to all of you after the presentation. So we're going to describe the biology of the human scabies mite, discuss transmission and risk factors, discuss the disease characteristics that patients experience, or some of the symptoms and things. We're going to describe the diagnosis of scabies, discuss treatment options and prevention and control measures, and then just outbreak notification procedures and just how to respond to reports of outbreaks. So the causal agent is the Sarcoptes scabii hominis, which is the human itch mite. And there are some pictures of what this little mite looks like. It's a disgusting little critter. And it's in arthropod class Arachnida, subclass Acari, and family Sarcoptidae. So these mites, they burrow in the upper layer of the skin, but they never go below the stratum corneum. So they stay up in that keratinized layer of the skin. The burrows, they appear as tiny raised serpentine lines that are grayish or skin colored and can be a centimeter or more in length. Other scabies mites may cause infestation in other mammals such as domestic cats, dogs, pigs, and horses, and I'm sure you've probably heard of sarcoptic mange in dogs and things. These different variants can cause infestations in humans, but with temporary itching and dermatitis, but they're usually self-limiting and they're not contagious from person to person, and they normally don't replicate in a human host. So there are 4 stages in the life cycle of the scabies mite, and this is in order of how it progresses. So you have the egg stage, the larva, the nymph, and the adult. The females, they deposit about 2 to 3 eggs per day as they burrow in the skin. And these eggs, they hatch within 3 to 4 days. And after hatching the larva, they migrate to the skin surface and they burrow into the intact stratum corneum to construct short burrows. And those little short burrows are called molting pouches. And the larval stage has 3 pairs of legs. So whenever you have a larva that emerges from the egg, they will have 3 pairs of legs. And this stage lasts about 3 to 4 days. Well, then the larva will molt, and after molting, it will become what's called a nymph. And a nymph has 4 pairs of legs. And I'll show you some pictures in just a minute just so you have a better idea of what I'm talking about. And later on, the nymphs will molt again, but they'll just become larger nymphs before they become adult scabies. The larvae and the nymphs may be found in molting pouches or in hair follicles, and they look similar to adults, but they're just smaller whenever you see a nymph. The adults, they're round, sac-like, eyeless mites. The females are 0.3 to 0.45 millimeters long and about 0.25 to 0.35 millimeters wide. And the males are about half that size, and I'll show you a comparison. And why do you think the females would be a lot larger? Eggs. Yeah, and that's what we see a lot in nature outside of mammals. Those who lay large amounts of eggs, the females are usually larger. Adults, or I'm sorry, I already said that, mating occurs after the active male penetrates the molting pouch. So after they burrow into the molting pouch, the male will penetrate that of the adult female. And it takes place only once, and once the male inseminates the female, she's fertile the rest of her life. So she'll lay eggs and produce mites the rest of her life. So once the female is impregnated, they leave the molting pouch and they wander on the surface of the skin until they find a suitable site to do a permanent burrow. Well, while they're on the skin surface, they use these little sucker-like villi to move and to keep attached to the skin. And that's on the 2 anteriormost pairs of legs, and I'll show you that in just a second. And so when the impregnated female mite finds a suitable location, she'll begin to make the little characteristic burrow, and she'll start to lay the eggs as she goes through that burrow. After the impregnated female burrows into the skin, she remains there and continues to lengthen her burrow and lay eggs for the rest of her life, which is about 1 to 2 months. Their lifespan is about 1 to 2 months. And then under the most favorable conditions, about 10% of the eggs usually will arise into adult mites. And males, they're rarely seen. We primarily see females and identify females. Let's see. And they make temporary shallow pits in the skin to feed until they locate a female's burrow and they mate. So they kind of stay hidden until they are on the prowl to find a female. Sorry, that did not sound. I didn't mean that the way it sounded. All right, and so here's just a diagram to show the life cycle, to summarize the life cycle of the scabies mite. So we have adult females, they deposit eggs in the burrow, and then the egg hatches into the larva, and then the larva they molt into nymphs, and those are found in the short burrows. And then mating occurs after a male, which is this one here. You can see he's much smaller than the female. Whenever a male finds a burrow of a female, and mating occurs then. And so here are some diagrams just to give you a better idea of what it looks like. So this is a cross section of some skin, and this is a scabies mite that's come and started to burrow into the skin. And this darker area here, that's the stratum corneum, that's the keratinized layer of skin. And then here is just a diagram showing you the burrow and then how she continues to lay eggs as she digs this burrow. Transmission. Transmission occurs primarily by the transfer of impregnated females during prolonged skin-to-skin contact. And Norwegian scabies, however, that is incredibly contagious, and I'll show you some pictures of that. Those can be spread just from brief skin-to-skin contact or from touching fomites or anything where a person has sat, like furniture or bedding or clothing that a person with Norwegian scabies has touched. And so human scabies mites, they're often found between the fingers and on the wrists of people. That's one place that you can always find them, is on between the fingers and on the wrists and the folds of the skin on the wrist. This is a diagram just to show you where typical rashes occur. They can occur everywhere on the body, but these are where we see them the most. So on the front, they're under the armpits, here in the abdomen and the groin area, and around the knees, and of course definitely here in the wrist and between the fingers. And on the back side, you'll see them usually here in the middle back, here on the love handles, and around the buttocks area, and sometimes down here on the heels. So as I said, these are where we typically see the rashes for scabies, but they can be anywhere. Of course, these are warm, moist environments, and so it's more favorable for their life cycle. So after the infestation the first time, a person may not have symptoms for 2 to 6 weeks. So they can be infested for a month or so before you realize it. And so they're contagious. They can pass this on to other people during that time. And if a person's been infested before, symptoms usually occur between 1 to 4 days after exposure, because what causes the reaction to this, it's an allergic reaction. And so once they've been introduced to it once, they have sort of a hypersensitivity. And so whenever they get reintroduced again, it's sort of a more immediate kind of allergic reaction, because they're having an allergic reaction to the proteins found in the eggs and in the feces of the mite. So, as I said, an infested person can transmit the scabies until they're successfully treated and all the mites and eggs are destroyed. So, disease characteristics, the most common symptoms, of course, are itching and a skin rash caused by the sensitization to the proteins in the feces of the parasite, which I just said. There's severe itching at night is the earliest and most common symptom. And then, of course, it causes a papular rash, and of course, they're itchy. And they can be found between the fingers, on the wrist, elbow, armpits, penis, nipple, waist, buttocks, and between the shoulder blades. And the head, face, neck, palms, and soles of infants are often, we can see them there too. We typically don't see that on the areas of adults, but in the kids, we can see it on the head, face, neck, palms, and soles of the feet. On with more disease characteristics, the tiny burrows are sometimes seen on the skin, and as I said, they're caused by the female scabies mite tunneling through the surface of the skin. The burrows, they appear as tiny raised and crooked grayish white or colored lines on the skin surface. And even though that you would think that an infestation would be quite a few mice, you may only find 10 to 15 at a time on a person. So the burrows, they're difficult to find, and it is difficult to get a good skin scraping if you're going to do that, because you have to find these burrows to get them out. And as I said, they're found most often between the webbing of the fingers and the skin folds of the wrist, elbow, or knee, on the penis, breast, and shoulder blades. This is just some pictures of what the rash looks like. You can see it is a papular-like rash. And there are some complications with scabies infestations, because the intense itching leads to scratching, and of course with a lot of scratching you can create skin sores. Well, these skin sores, they can become infected with bacteria that are on our on our skin, or that we come into contact with One is Staph aureus, or beta hemolytic streptococci. And so, they can go on and to progress in more serious conditions, especially if you're dealing with an immunocompromised host, and it can cause inflammation of the kidneys and, which is called post-streptococcal glomerulonephritis. So it can lead to some complications. Now, the crested Norwegian scabies. This is a very severe form of scabies, and we see this in the elderly a lot, immunocompromised people or people who have conditions that prevent them from scratching or itching. So let's say that they're paralyzed, or they've had some type of injury, or they just have a lot of limited mobility, or they've lost a sensation, or they're they don't have the mental capacity to really register or understand what's going on. This particular condition is characterized by vesicles and thick crusts over the skin that contain many mites. And itching may be absent in crested scabies because of the patient's altered immune status or neurological condition. And because they're unable to feel them or know that they're there, they tend to get these huge infestations. And here's some pictures of that. Because they're infested with large numbers, and they can have up to 2 million. I told you a typical infestation is about 10 to 15 mice. Well, they can have up to 2 million with the Norwegian scabies. And what it is, it's not a different species. It's the same mite, but they're just not able, if they've gone untreated and they can't scratch, or they are not aware of it, they'll just keep causing skin damage and replicating, and you'll get these big crusted lesions. And so these folks are highly contagious. So as I said, if this stuff flakes off, they shed. We shed skin cells all the time, but these folks, with the crusted lesions, they're shedding mites and larvae and nymphs all the time whenever they're with this stage. So the diagnosis, a lot of times, unfortunately, diagnosis is just made clinically. A person will present with rash, a clinician will say that's scabies, and then they'll give them some cream to use for that. However, we recommend, whenever possible, that it's confirmed by identifying the mite or eggs or fecal matter under a microscope by collecting skin scrapings. So, identifying the mite eggs or scabiella, which is the feces of the scabies mite, it can be done by removing the mite at the end of the burrow by using a sterile needle, or you could obtain the skin scraping, which is typically what we recommend. A person can be infested even if mites, eggs, or fecal matter aren't detected. And we've had that instance before. We know that the person has scabies, but even though they've gotten scrapings at multiple sites, they just didn't find a burrow that could yield, a good specimen. So they can be, even if you don't isolate anything, they can still be infested. And so if they have the clinical presentation, if it doesn't seem to be going away, then we'll recommend that they be treated. And then, of course, whenever skin scrapings are collected, we recommend multiple sites per patient are collected. So whenever you do the skin scrapings, it's best performed at the end of the burrows in non-excoriated or non-inflamed areas. And then on the scalpel blade, you use a scalpel to scrape the skin. You put a drop of mineral oil on there, and as you scrape that mineral oil helps with the adhesion of the mite to the scalpel. And then it can be transferred over to a glass slide. And then once you get on the glass slide, you can add a few more drops of mineral oil to that before you put a cover slip on, just to make sure it sticks on the slide. And then, of course, you need a microscope to look at this. That's one of the problems that we have a lot of times in long-term care facilities, especially in smaller communities, is that they don't have a laboratory that would do this. And so we just, we recommend that they ask around to see if Quest, sometimes they will do this. And that's what we've done in the past. Actually, I think one of our regional, Dr. Marion Pennington, she's a veterinarian. She actually did a skin scraping, and identified a scabies mite from a person there. So I'm not saying contact Dr. Pennington to do these, but it can be difficult, and so you may have to ask around to see who would be willing to do it. Sometimes hospital labs will do it, so you just need to check around. And in the guidance that we have, there are detailed procedures on how to collect it and how it needs to be looked at under a microscope and things too. So so it's in more detail, and I'll be happy to share that information with you, or I can give it to Joy and she can send it out with the presentation. And then the skin scrapings, of course, these are for the laboratories. They should be screened at 40x or 100x, and then evaluated at 200 to 400x for confirmation. For treatment, there are several options for treatment. However, there's only one that's really recommended and the most effective. The things that we use to treat scabies are called scabicides, and they're only available with a doctor's prescription. You can't get anything over the counter, and nothing over the counter has been approved to treat human scabies. I know a lot of people will say, well, I used vinegar and it worked, and well, I'm not sure about that. So this is by far the best method of treatment and the one that we recommend. And of course, the best one is the permethrin cream, 5%, and it comes in the brand name Elamite. You've probably heard of that. It is approved by the FDA for the treatment of scabies in people who are at least 2 months of age. And it actually is from an extract of the chrysanthemum flower. It is safe and effective if it's used as directed, and we haven't really been made aware of any adverse reactions from people in long-term care facilities who have been prescribed this and used it. It will kill the scabies mite and the eggs, and it is the drug of choice, as I said. And you may need 2 or more applications about a week apart to eliminate all the mites, especially when you're treating Norwegian scabies. Another treatment is Crotomyton lotion or Crotomyton cream. And the brand names for these products are Urax and Crotan. This is approved by the FDA for treatment of scabies in adults, but not for children. And they have noted a lot of frequent failure with this particular cream. And then another one is Lindane lotion. There's not a brand name available in that. It is FDA approved, but it's not recommended for the first line of therapy. Permethrin is by far the drug of choice. So it should be used with premature infants or persons with seizure disorder, women who are pregnant or breastfeeding, persons with irritated skin or sores. The permethrin has been shown to be the safest and most effective. And then ivermectin, that's an oral antiparasitic agent that is used. If people can, and they prefer that you use the cream, the topical cream, but if that does not work, then we can resort to ivermectin. Or if a person just has no tolerance for the creams, they can be given ivermectin. And then a total of 2 or more doses, at least 7 days apart, may be necessary to eliminate scabies infestation. Let's see. Yeah, and it is reported effective in the treatment of crested scabies. And as I said, it should be considered for patients who fail treatment with the cream or can't tolerate the creams. And then in addition to those who are infested, we also recommend treatment of household contacts, especially those that have prolonged skin-to-skin contact or sexual partners of an infested person within the preceding month, because as I said, they can be contagious for up to a month or so after they become infested. So they recommend treatment of all those household contacts, and all people should be treated at the same time to prevent reinfestation. The scabicide lotion or cream, whenever you apply it, it needs to be applied in adults from the neck down to the feet and toes, especially under the fingernails and toenails. A lot of times they forget that area, and that's where they go, especially if you're scratching a burrow, you can get those under your fingernails. And so it's really important, and oftentimes they'll forget that area, and then what do? They scratch once they go through the treatment, they scratch and they reinfest themselves from what was left under the fingernails. So it's important to get under the fingernails and toenails. And when you're treating infants and children, the scabicide cream should be applied to the entire head and neck because, as I said earlier, with children it can affect their face, scalp, and neck as well as the rest of the body. And of course, it should be applied to a clean body and then left on for the recommended time. And I think it's usually 12 hours. I think 8 to 12 hours, I believe, is what it is for permethrin. And then clean clothing should be worn, of course, after treatment. And of course, all the bedding and everything needs to be cleaned and laundered and washed in hot water and put through a dryer cycle and things. And I'll talk about that in just a second. And because the symptoms of scabies are due to the hypersensitivity of the reaction to mites and their feces, as I mentioned earlier, they still may have itching for several weeks after they've been treated, even though that the mites and eggs are killed. So a lot of times people will think that they're still infested, or facilities will be concerned because the person still has a rash and they're itchy. But it is an allergic reaction. So even after treatment, and even if the mites and eggs are dead or killed, we'll still see some symptoms of it. So it just requires some pretty astute close monitoring, just to see if that actually spreads. If it does spread, if the rashes get bigger or they get more intense, it could be an indication that there is a continued infestation. And of course, if itching is still present more than 2 to 4 weeks after treatment, or new burrows well, I just said that, retreatment may be necessary. So some prevention and control strategies. Of course, you want to avoid skin-to-skin contact with an infested person, or with items such as clothing or bedding that's used by an infested person. As I said earlier, treatments recommended for all household contacts. And people with crusted scabies and their close contacts, they need to be treated rapidly and aggressively to avoid, outbreaks, because that is so contagious. The bedding and clothing and towels used by infested people need to, and their household sexual contacts, they need to be decontaminated by washing them in hot water and drying them in a hot dryer. And if that can't be done, if they can't launder it and put it through a dryer cycle or dry clean it, seal it up in a plastic bag for 72 hours, because these mites, they don't live more than 2 to 3 days without a human host. For institutional outbreaks, they can be difficult to control. So, it's really important that we are made aware of them early on. So it's important to, build relationships with the long-term care facilities. We've gotten really good with long-term care facilities regarding influenza and norovirus. They're really quick to notify us of that. But for some reason, they're a little hesitant about scabies, and I'm not sure exactly why that is. So it's important to let them know that we're there to help them, and we're not, into the regulatory business. We want to try to help them and help their residents and prevent further infestation. So we need to build that relationship with them. So it's important to be made aware of that early on. Rooms used by a patient with crusted scabies, of course, they need to be thoroughly cleaned and vacuumed after use. And environmental disinfestation using pesticides or sprays, that's not necessary. And we often discourage that because some folks have done that, but they can be really toxic, and it's not necessary. So if you just do a really good environmental cleaning, use your approved cleaners and vacuum, then that should be enough to take care of it. So outbreaks in healthcare facilities. A scabies outbreak in a facility suggests that transmission may have been occurring within the institution for several weeks, because it could take a few weeks for the symptoms to appear. And which, of course, this increases the likelihood that some infested staff or patients or their contacts may have spread that elsewhere in the community. So measures to control scabies in the institution will depend on several factors. How many cases are diagnosed or suspected, how many infested persons have been at the institution while undiagnosed or unsuccessfully treated, and whether any of the cases are crusted scabies. So the local health department should be notified early on of any outbreak that may have community implications, including the possible spread by patients or staff to other institutions. Then once the local health department is notified, the local health department should notify us and talk with us about investigation of the outbreak and implementation of control measures. Because there is some information that we want to gather, and if we do think it is an outbreak, we'll assign an outbreak number and we'll track it. And then, of course, we encourage open and cooperative communication between public health and the facility at all times. A lot of times, whenever we have a long-term care facility involved with the scabies outbreak, I'll often call the director of nursing too, or do a conference call with the regional epidemiologist or the local health department nurse to discuss ways that we can work together to treat who's affected and prevent further cases. So I'm going to go through a few different scenarios and kind of summarize the actions that should be taken. And of course, we have a more detailed documents, and I'm working on putting the best of the resources that we use together into one document for Kentucky. And so in healthcare facilities, if you have a single case of non-crusted scabies, Of course, you should heighten surveillance, and you want to be looking for new cases and work with the nursing staff there. Have them do head-to-toe checks, once or twice a day, just to be on the lookout for any new cases. You want to use proper infection control measures, when handling patients. So you want to avoid direct skin-to-skin contact with that patient who is infested. We want to try to get confirmation of it. So we want to try to obtain skin scrapings to confirm the existence of scabies there. We want to do early treatment, and we want to do complete treatment. So we want to follow all those treatment guidelines, cover from the neck down, under the fingernails, under the toenails. So it's important that we do that. And we may even do prophylactic treatment of staff and other patients that have had prolonged skin-to-skin contact with the suspected or confirmed case. Skin-to-skin contact with scabies patients, they should be avoided for at least 8 hours after treatment. So after they get treated, wait 8 hours before there's any skin-to-skin contact made. And then, of course, we want you to provide information to the facility regarding the identification, treatment, and control of scabies. And a lot of times I'll do that too, forward information to local health departments and to the director of nursing or whoever we're working with at the long-term care facility or other healthcare facility to give them that information. So for multiple cases of non-crested scabies, you're pretty much going to do a lot of the things that we just mentioned for the one case. The heightened surveillance, you want to do infection control, confirmation, you want to do early treatment and follow-up, prophylactic treatment, avoiding skin-to-skin contact. And then they should also do an institution-wide information program that needs to be implemented for all their staff, all their management, nursing, and support staff to let them know that there is scabies in the facility, which honestly I think that should be done with one case so everybody's aware of it and they're taking the proper precautions. And then if there are more than one case, we're going to start looking at some epidemiological and clinical data. And so we're going to request probably a line list, and then we'll work with the epidemiologists to get an EpiCurve, because sometimes by the time we're brought into these, there are maybe 5, 6 cases before they'll notify public health, because they're aware that it's gotten out of control. So for multiple cases of non-crested scabies, this is just a continuation from the previous slide. We're going to provide information to the facility, and then we'll request a line list with the following information. And I do have a template for this that I'll send out. So it's already like an Excel spreadsheet, and so you can just fill in the information. And a lot of times it's easier for the long-term care facility or the healthcare facility to complete it and then email it to us. And so we want to know the floor of the unit that it's in. It's also helpful to get a map, if possible, to show where the cases are. And we've done that with other disease investigations. We'll request, if it's in a facility, we'll want to get a floor diagram so we can see and then figure out how the staff is shared between all the different wards or the different floors and things, and see if there may be the potential for some from carrying it from one unit to another. And so those are important considerations. We want to get the patient or staff name or initials. We're okay with the initials as long as you know who you're dealing with. If you send that to us and it's just initials, that's fine. You don't have to protect that or anything. We want the symptom onset date, the date of diagnosis, the type of diagnosis that was done, even if it was just from clinical presentation or if they actually did skin scrapings and received lab confirmation. The date the skin scraping was collected, if one was collected, what the result was, if it was positive or negative, and then the type of treatment that was given, and then the treatment date, whenever they were given the first one. And then, of course, after monitoring, we want to know if the symptoms resolved after the first treatment, and if they didn't, what was the date of the second treatment, and then what date did the symptoms resolve after that. So there are just some pieces of information that we'll request with the healthcare or a scabies outbreak of more than one case in a healthcare facility. Now, for one or more cases of crested scabies, this is one or more, of course, as I said earlier, rapid and aggressive detection, diagnosis, infection control, and treatment measures are necessary because it is extremely contagious or highly transmissible, not really contagious, but highly transmissible. So, of course, unrecognized crested scabies is often the source of the institutionalized outbreaks. We've had a few cases of that where they brought in an individual from another facility who had crested scabies, and they didn't tell, of course, the receiving facility, and it kind of went crazy from there. So not only did we have it in the original facility, but we also had it in the new facility too that we had investigated. Of course, infection control personnel and dermatologists should be involved as soon as possible. And of course, the institution-wide information program should be implemented. And then until they're successfully treated, all patients with crested scabies should be isolated from other patients who do not have crested scabies. And then of course, you want to assign just a certain cohort of caretakers just to take care of that particular patient with crested scabies or the multiple patients with crested scabies. You don't want them going on to other uninfested patients because they could spread that just due to the nature of this. And of course, direct skin-to-skin contact should be eliminated following the strict contact precautions. And of course, you need to use gowns, gloves, and shoe covers and things too whenever you're going into the patient's room and doing any kind of care with them. The patient's room needs to be cleaned thoroughly, and we actually recommend this for all scabies patients. This room should be cleaned thoroughly, and bedding and clothing should be machine laundered and hot water and hot dryer cycles. You want to wipe down all the surfaces. You want to do vacuuming and things too, especially the furniture. People who have been exposed to the patient with crested scabies, if they've had skin-to-skin contact or contact with their clothing or furniture or anything, they need to be identified and treated because more than likely they have come into contact with it if the person does have a weakness scabies. And as I said, it should be considered even if there is some complexity of it, just because of the complexity of dealing with Norwegian scabies, treatment needs to, of course, be considered for all those contacts. All suspected and confirmed cases should be treated at the same time because as I said earlier, just to prevent the reinfestation or re-exposure. So everyone you want treated the same day. And then if there has to be any kind of repeat treatment, you all get treated or retreated at the same time again. And as I said, symptoms of scabies can take weeks to appear the first time, but they can spread it during that asymptomatic period. And then people with crested scabies, they usually require 2 rounds of treatment to be effective. And of course, treatment with permethrin is what is recommended. Long-term surveillance is imperative to eradicate it from the institution. So once we receive a report of crested scabies, we kind of follow up for several weeks just to make sure no other cases have cropped up. And long-term care facilities will continue to do head-to-toe checks and things too, looking for rashes. All new patients, they need to be screened and treated for skin conditions. They're suggestive of possible scabies, and so that's another education point that we can try to get out with them and work on our relationships with them, just to make them aware that anytime they receive a new patient, they should just make it a practice just to do a head-to-toe check just to see if they do have any kind of suspicious-looking rashes. And the local health departments and neighboring institutions, especially those who have received patients that may be infested, they need to be notified and made aware of the situation. And of course, as with the others, whenever we find or are made aware of one or more cases of crested scabies, we'll ask for a line list with all that same information on it. And we have come to the end, and these are some resources that you can use. We use, of course, the CDC Scabies webpage, where a lot of this information came from. The 2 guides that we use most of the time for scabies is the Management of Scabies Outbreaks in California Healthcare Facilities, which was created by the California Department of Public Health and their Division of Communicable Disease Control. And then another reference is the Scabies Prevention and Control Manual, which was created by the Michigan Department of Community Health. And then, of course, and I know I focus primarily on healthcare facilities, but in the guide that I'm creating, we're going to talk also about schools and daycare settings because we've also had some scabies outbreaks in daycare. So it's important, too, to be vigilant in those and increase surveillance. And so the Hennepin reference, the infectious disease and child care settings in schools, has fact sheets and things for parents and some technical information for the facilities and things that you could use as well. So, any questions?
Let me make sure that I'm clear. Scabies is not a reportable disease.
No, it's not a report, yeah, let me make that clarification. An individual case of scabies is not reportable, however, outbreaks are. So if you do get, a report that there is an outbreak, or, a healthcare facility may contact you and say, hey, I have a case of scabies. Well, that's when we would just say, okay, well, here's what you need to do. Here's the recommendations and the control measures and things. We don't really have to do a whole lot of action with that, but we'll want to follow up with them just to see if they've had any other cases that may have cropped up. And so we'll want to let them know that if you do see other cases, let us know about it, because we want to try to prevent.
This is their responsibility.
Yes, it is their
It's not something that we're going to delve into like we would a case of salmonella.
No, absolutely not.
Now,
No.
Second question is, I don't have so much trouble with my nursing home as I do with my school.
Mhm.
All right, the high school every year will have 2 or 3 cases. We've given them the information, but the school system has had their own protocol as to follow up, and they have their own school nurses.
Okay.
So how involved do we get? Are we talking about getting involved in schools? I mean, daycares will also call, but I've never really gotten, I've never jumped into that.
Yeah, I don't think
arena.
and I don't think we're going to require that of you too.
Okay.
I mean, we're not going to require that of you to jump into those, if you
Okay.
have a few cases now, if you have a large 25 cases, in a school, then we would probably, want you to get involved with that. But for the 2 or 3 that you get in a school, if you give them the guidelines that they follow that, and if they do have a protocol that is effective, then let them follow that.
Okay.
But then just let them know to contact us if it continues.
Well, most of them follow that, the guidelines for children, and, and that's what they use as their resource. So we're all using the
Great.
same resource,
Perfect.
we're all on the same page. I just want to know how involved you would be.
Yeah, for the community-wide ones, the healthcare facility ones are the ones that we would probably get more involved in. As I said, with one case, we would give them the information, say, let us know if you see any more, and then kind of maybe follow up just to see if they, had a
Well,
case.
and the last question is, I mean, this is something that's been sporadic over the years. Are you saying that scabies has become more of a problem? Are you seeing a lot of it?
I've received more, well, in the last year or so, I have received, quite a few calls. We've had a few long-term care facilities that have had some significant issues, due to, one case was due to Norwegian scabies.
Okay.
So we have had a few more, and I don't know if it's just where we're just getting involved more, giving more information. So I've just gotten more calls, and so we just thought it would be a good idea just to get everybody on the same page with it. So, well, all right. Thank you, Joy. Appreciate it.
Thank you, TJ. Any other questions from the field before we let TJ go?
No, but I do want to say he's just wonderful.
Oh, well, thank you.
Thank you,
Well, I
Joanne.
appreciate that. You made me blush.
Thank you for confirming that.
Well, thank you, Joy.
Well,
Thank you,
Did
Joy.
you get your number out?
He gave it to me.
Okay, all righty. Thanks again, TJ. Next. You made TJ's face turn red, Joanne. Next, we're going to have our flu program update. Jan Hatfield with the immunization program is our influenza coordinator. And most of you all should be receiving her weekly updates on the influenza status and report. And so I wanted to invite Jan to have the opportunity to review any updates and helpful hints and information regarding influenza. So thank you, Jan, for coming. I know you've been really busy, and you went out on the 13-site tour, I think, the statewide tour. So you're just getting back and unpacking your bags as well. So thank you for coming and speaking to the nurses today.
Thank you, Joy. Thank you, Joy. I've been with the program for about 10 months now, so this has been a new journey for me. And I've learned a lot. I've never been really involved in surveillance before, so it's been very, very interesting for me. So I appreciate you all standing with me and the questions and the comments that have came in, so thank you very much for that. Just a quick review. As you know, we've been at the regional status for the flu for the following 3 weeks. We've had 60 confirmed cases of influenza. We had 62 confirmed cases the previous week. So hopefully we're starting a downswing. We'll see. We had 12 out of our 15 Kentucky ad regions that had confirmed flu. However, the cases have dropped dramatically in those counties. Also, we've seen a decrease in our influenza-like illness across the state. We're waiting to see if that was maybe because of schools being out so much for the winter, but right now it's really on a downswing too. Kentucky has been designated as low for ILI activity for the last 3-4 weeks. We've had 1 pediatric death in Kentucky so far this season. And as you all know, all pediatric deaths under the age of 18 are required to be reported that are influenza-related deaths to the Department of Public Health. Long-term care facility outbreaks. We've had 11 documented so far this season, and that's compared to, we've had over 58 outbreaks reported to us at this time last year. So that's been not quite as bad so far. But just as a reminder, if you have any long-term care facilities in your areas that have 2 or more residents or staff with ILI or a positive flu test, to get in contact with your regional epidemiologist or your local health department nurse, rapid response nurse, and give us a call. We'll get you the paperwork and get you started on that investigation. Nationally, the proportion of people visiting providers for ILI is declining overall, but they still feel like the flu season will continue on for several weeks. This flu season particularly, the predominant flu strain has been influenza A 2009 H1N1, which is what we saw in 2009 and caused the pandemic then. That's predominantly what we're seeing right now, and it is affecting young and middle-aged adults. We've had 60% of reported hospitalizations in people aged 18 to 64 years of age across the United States. So it is primarily affecting this age group, and unfortunately this is the age group that is less likely to get a flu vaccine. So influenza-associated pediatric deaths across the United States. There were 10 reported deaths within the last week. There's been 50 overall across the United States. We've only had the 1 so far. Let's see. Of course, we're still recommending that you encourage annual flu vaccine for everyone, and still encourage anyone 6 months of age or older to get a flu vaccine. It's not too late to go ahead and get that. We've had no news yet on the new formulations for next year. ACIP actually is due to meet next week to evaluate this season's vaccine effectiveness, as well as this season's influenza activity and vaccine efficacy. So hopefully after that, we'll be able to know something about what's going to happen for next season. There will be 2 articles of interest that are going to be appearing today in the MMWR. The interim estimates of the 13-14 seasonal influenza vaccine effectiveness to date February 2014 is supposed to come out today, as well as an update on influenza activity in the U.S. from September 2013 to February 2014. So those may be of interest if you want to look those up. From our immunization program, VFC vaccine is still available out in the state. It can be moved if needed. If you have any need for extra vaccine, we've got all formulations available so far. Contact Laura Herod by email, and she can coordinate getting that moved for you. She's on the global, laura.herod@ky.gov. VFC pre-booking for next year, of course, is due tomorrow, February 21st. Your VFC contact should have received a memo. It went out from our immunization program on February the 7th. And if for some reason your health department didn't receive a memo, give us a call, let us know, and get your orders in. So, anybody have any questions for me? Thank you.
Thank you, Jan. Appreciate your time and updates on influenza. It's good to hear that the ILI cases are, and the flu cases are declining. We hope that continues. Next, I'd like to introduce Christy Royalty. Christy is a registered nurse, a nurse consultant with inspector with the Family Planning Program. She's here to provide a brief update and an overview about an email she sent out to everybody yesterday. In the Division of Women's Health, we're deep in the throes of grant writing time and data collection time. So Christy sent out an email late yesterday afternoon, so I said, why don't you come up and share that with the nurses? And so she's here this morning to do that. So thank you, Christy.
Good morning. It is still, well, no, now it's noon. I'm still very itchy. I don't know about you all. I think I saw everybody in the room here at least scratching a couple of times, thanks to TJ. But thanks, Joy, for the introduction. I am with the Family Planning Program now, and we are, yes, have started the grant, the budget, allocations, and everything is going on. And I just wanted to put a plug in that yesterday afternoon I had sent out an email just requesting information, updated information on your family planning service sites, your hours of operation, and the services you provide. And in the next couple weeks, we'll need that information in. So if you can just email me that information, I'll update the tables on the documents I sent to you. And if I can get those in by the 5th of March, that would be great.
And all that will be compiled?
Yes, we'll be compiling that. That all goes into play in our monies that we ask for in the grant, and what we can allocate to you guys out in the field. So that will all be compiled for that very important grant. So if y'all have any questions, again, just look for my email or give me a call. I'm on the Global.
Thanks.
Thank you all.
Thanks, Christy. Okay, I think we're ready to wrap it up with some nursing office updates. I have several, so I promise it looks like we're a little bit ahead of schedule, so I think I'll be able to get them all in. Wanted to let you all know that Danelle Bray, who we had announced at the last PHNITV in December, was going to be helping out a part of her time with the nursing office. She has retired, and so we're very happy for Danelle. I'm very unhappy because I've lost Danelle. So anyway, just to let you all know, she's retired, and I'm sure she's got a lot of exciting plans ahead in her future. Before she left, though, I do want to share that one of the projects I asked her to work on was updating the nurse leader list that's on the local health operation page. And I had gotten feedback from several of you all that, said, Joy, this information's a year old, or, whatever. And so she did compile and contacted everybody and got the most updated information. So I did get 2 updates yesterday. So what I'll do is make those corrections, those revisions, and get that out on the local health website, local health operations website. I'll ask Mary Mullins to post that, and I'll probably just send that out as a Word document for you all as well, so you can print that out and have easy access to it and use that for your reference. I also wanted to mention, as TJ did, about the upcoming KPHA conference. The Nurses Luncheon, which the nursing office sponsors each year, will be held on Tuesday, April 15th from 11:30 to 1. Lunch will be provided, again, as a perk to public health nurses. So that would include our DPH nurses, our local health department nurses, our school health nurses. And so I really hope that you all can join us. You would have a ticket. Make sure you check on your KPHA registration that you plan to attend the nursing office luncheon. So that will generate a ticket for you that you'll have in your little name tag pouch, because you'll need that ticket to be able to participate in the luncheon. Our CE speaker this year is Carla Bowman, who many of you all know and love as a previous nurse leader at the Madison County Health Department, and she's going to be speaking on community mentoring. So for those of y'all who know Carla, or those of y'all who don't know Carla, she's such a wonderful speaker and has decades of public health nursing experience to share. So I'm looking so forward to having her come and speak to the group again this year. We had about 100 public health nurses join us, and so certainly at the lunch last year, so certainly hope to have 100 or more again this year. Wanted to let you all know from a women's health perspective, as Christy mentioned, the Family Planning Annual Report, which is our data report, was due to the Office of Population Affairs, which is our funding agency for the family planning program. That was due on Tuesday, and so that was submitted. Thank you to everybody. I know we had sent out a Survey Monkey for everybody to contribute your agency-specific data on your FTEs, I believe, and some other information. I do want to report that the overall user numbers for the calendar year 13 the numbers were down 11.2%. Since I've been around for the last 12 years or so, the numbers have been for family planning numbers have been right around 100,000. Now they're about at 86,000. So that's a significant decrease. So as a part of our data submission, we review that data, look into the possible causes and what happened, what the impact was on family planning services, the decline in family planning services, and what all the factors went into that decrease. So we've submitted that report, and more information will be provided next week at the Division of Women's Health ITV, which will be next Thursday, the 27th. Wanted to also let you all know that the Kentucky Women's Cancer Screening Grant is being submitted right now as we speak. Melody Stafford, the program director, she was here early in the morning, but she had the grant ready to go and to hit the submit button to the CDC. We were allowed to request level funding, and so that's certainly what we did for cancer screening, breast and cervical cancer screening services for the upcoming fiscal year. So I wanted to let you all know that that had been submitted. Let's see, on Tuesday we had the Women's Health Update, which Dr. Rowland, who's a radiologist surgeon, and Dr. Connie White, and Carolyn Kerr, and Teresa Wren all presented. It was a 3-hour CE, and I hope that many of y'all were able to join us. We did have over 200 participants, so that was a great turnout. I was able to listen to Dr. Rowland, and she was a wealth of knowledge and had some great information to share with everybody. So thanks to Libby Hess and Carolyn and to Lori Knudsen from the Madison County Regional Training Academy for making those arrangements for that ITV. And then lastly, I wanted to share that you may have received an email from Dr. White late yesterday afternoon that Governor Beshear will be announcing his new health initiative through a press release today at 1 p.m. in the Capitol. And we will be sure to release the report and the initiative, the details, after the press conference. You may recall that the governor mentioned his health initiative and forthcoming information in his budget address, and so it's here, and so we're looking forward to that, and we'll be sure. I'm sure public health and health care initiatives will be mentioned, and so we'll be sure to share all that with you all and how that may impact public health.
Lori, I think she sent out.
Yes. A YouTube link. Thank you, Nancy. Dr. White sent out a YouTube link as well, so you could view it live. If you didn't receive that, let me know, and I'll send that to you. I can't remember. Did she send that to DPH everyone, or did she send to all of the health departments? Okay, okay. I'll send that out real quick before I go over there, so everybody can have that availability to watch it live if they want to. Okay? Any questions? Okay, we had a great, I think a great ITV today. Thank you all so much for your participation and for all that each of y'all do each and every day for public health. We appreciate you so much. Again, this will be archived, so let me know if you have any questions. And as soon as I get those archive sessions get a different train number. So as soon as I get that number from Vi Valen, I'll be sure to send it out to everybody. Thanks so much and take care. Bye-bye.